on the right side. Just
So that's a very important point that we were going to point out later on, which was when you do your first TISA, we might all not do micro TISA because of course you need a bigger team for that. Make sure we send a biopsy. So in case the next time when the person who's going to do a micro TC can counsel, you'll get either Sertoli cell, you get hypospermatogenesis or maturation arrest, late maturation arrest, early maturation arrest, and everything has a prognosis rate. The worst, of course, is with Sertoli cell, but the best is with hypospermatogenesis and late maturation arrest. The second, of course, is before you do a micro TC or a TSAP, make sure you do a Y microdeletion and a karyotype if possible. Because if you have a Y microdeletion positive patient with A and B, then there is no point doing a micro TSA. You might just spend lakhs of rupees on the patient. You are never going to get a sperm. And if you have a Y microdeletion C, you need to be the chances of getting sperm increase, but again, you need to counsel that it is an inheritable disorder, so that same couple, if has a male child, will carry a Y microdeletion C from the father. I think we'll take this up as the last case and we'll finish off. We've done a lot of male because usually stimulation female part, everyone knows what to do. One female case, which is the most common these days, is low AMH. A 34-year-old female from Mumbai with an AMH of 0.2, uterus normal on scan, AFC 2 and 2, investigations are normal, the husband has 2 million count and 10% motility. Any one of the panelists, please.
I will start this patient HMG stimulation because this patient is elderly, low AMH and this. And with also I personally prefer antagonist protocol.
Correct.
Right? And
so basically, as Sir says, you have to go for an IVF. That's the first choice. But the big question, of course, is to do or not to do, which is, would you want Sir to give them 3 months of pre-treatments with DHA, XYZ, and then take up for IVF, or you want to straight away take for IVF?
Also, I think, what is the characteristic of the woman? I think if she is maybe thin,
right,
if her insulin levels are okay, then by the time you're working her up, I don't know whether any patient at this point of time will be justified in waiting for 3 months.
Correct.
Right. So, and when we know that even by giving DHEA, whether or not you're going to actually help her or not, scientifically it's not yet proven.
Correct.
So, in the while that you're working her up, you give her DHEA, that's up to you.
Do you have any preferred pre-treatment, Vaibhav?
No. At this point, I want to get her pregnant as soon as
I
possible.
prefer one pre-treatment that is for synchronization of this cycle.
Okay.
For pre-treatment estrogen. That I will prefer in this case.
That is for a good cohort. Correct, sir. So as Dr. Vaibhav pointed out, we planned an IVF immediately. Something any panelist can highlight a little bit about what stimulation protocols for poor responders especially, or how do you want to stimulate them and what do you want to do? Just in brief, if anyone can take up.
So in literature now they say that minimal ovarian stimulation is the new for poor responders. But in our center, what we do if a patient at that age with low MH comes is counsel them for embryo pooling. Like we tell them that one cycle might not be enough, and if they are too rigid about their own eggs, then the other thing that we have recently started doing is an ovarian PRP. It is again a very experimental thing, but we are definitely getting more number of retrieved oocytes. And the protocols that we use is that the first cycle is an antagonist cycle, followed by PRP in the same sitting, followed by a 1-month gap where we give an OCP to make the cohort in one size, and then give the second stimulation protocol as a microdose long protocol, and we pool the embryos and then plan ahead. This is what we are doing in our center as of today.
Vaibhav, you want to throw some light?
So I am in this patient, I am directly go for a optimal stimulation, higher dose, not for a chance. Why minimal dose?
So what would
already
be your
4
dosage?
Follicles is there.
So what would you start with? What dosage?
In HMG, I prefer the HMG, and this patient 375 or maybe 450. Straightforward. And
Do
then
you like to use
antagonist
growth
protocol.
hormone for this patient? Growth hormone?
Growth hormone may be little help, but I have experience, but it is a empirical, not good. And this patient, if I go for this pickup and then after 5 days, if 4 good quality eggs, M2, then after 5 days, I will also monitor the embryo growth. If at least two embryo are growing good with 2 blastocysts, then I will not plan for second stimulation. And once pickup is finished, and after 5 days, if one or not growing, then I again after 5 days give second stimulation. That is my protocol.
So you basically do a dual stimulation, the luteal phase stimulation.
Yes, this patient.
The only thing where I probably maybe not differ, or maybe what's everyone doing is, when we have when we have a fewer number of embryos, and we want to go in for a dual stim, like sir saying, what we do is try and freeze them probably day 3 and not
Correct.
wait until you go to blastocyst. You get another set of stimulation, you get another set of embryos which you again freezing, and then you decide whether you want to thaw them and let them proceed to blastocyst at that point of time. So you have at least something in hand, and you have a little more number of embryos to choose from.
Correct. So two very important points have been highlighted. One, of course, with poor responders is how do you want to... First, of course, is to counsel, as Dr. Mridula said. Counsel the patient. Number of eggs are going to be less. If ready, always prepare them for another pickup. The another pickup could either be, of course, a conventional pickup where you stimulate, pickup, period, again stimulate, pickup. Or else, as Sir mentioned, you could do a luteal phase stimulation, which is a dual stim, wherein you do your pickup. It has to be an antagonist pickup. It has to be an agonist trigger to do a dual stim. You cannot give an HCG trigger and start from the 5th day. If you want to do a dual stim, which is the second luteal phase stimulation, give a agonist trigger, wait for 4 days, 5th day, blindly just start another cycle of gonadotropin. And the third point, which Dr. Vaibhav pointed out, is when you are kind of doing these oocyte pooling or embryo pooling, freezing them on day 3, then do another stimulation, collect your embryos, then take a call. You want to transfer day 3, you want to transfer day 5, you want to do a day 3, push them to day 5 and then transfer, that's your call. So this patient, of course, we retrieved 3 eggs, 2 were M2, 1 M1, 2 fertilized. Now, we've already discussed that, it's your choice, freeze them on day 3. We personally froze them on day 3. I didn't take them to a day 5 because I had only 2 embryos and we had planned another stimulation. So everything has been covered by the panelist here. So, of course, what next? Again, what they said is stimulate again or just transfer. Would any one of you do a fresh transfer here? I think that's the only so-called indication left for a fresh transfer these days. Would you take that risk? Koi hero banna chahega?
Only if the patient is going away.
Only if the patient, correct. If the patient doesn't want a second transfer, there is no time, or doesn't want to pay you for freezing, whatever. But there is... So the point here to make is you still have an option of a fresh transfer here a little bit somewhere because, and of course, if you've monitored your progesterone level when you've given the HCG.
Here I would like to ask a few questions to my embryologists. Sudesh sir, Ankit, Lister, what do you prefer? A day 3 embryo freezing or a blastocyst freezing, and why? Ankit, what to answer?
Actually we do day 3 freezing. Second month we thaw the day 3 embryos and cap for the blastocysts. Then we get 2-3 blastocysts, then we can implant into the uterus. This is our protocol.
And what about you, Lister?
Yeah, I would be kind of different. I would freeze them at day 5, looking at the grade of the embryos at day 3. Okay. I look if they are grade 1 and I feel like they are going to proceed to blastocyst. I would rather freeze blastocyst because blastocyst transfer of frozen blastocyst, then they would give better results in the end. So.
And Sudesh sir, what is your opinion?
We have been doing both, because of vitrification, we get almost 80 to 90% survival. Yeah. But what I would personally prefer, I would prefer to freeze day 3 embryos. See, day 5 blastocysts, you freeze, you will get survival, you will transfer them after 2 hours. But when you freeze day 3 embryos, what we do, we culture them. And we see out of those, say we have frozen 3 or 4 day 3 embryos, you will find just 1 or 2 blasts. So there I know which ones to transfer. There only I can do a selection. One of them may have got arrested, which you can't do when you freeze, blast and then transfer them immediately. So personally I would prefer to freeze day 3, culture them, and whichever becomes a blast, sometimes none of them become a blast.
Correct.
Then there is no point in transferring because they all got arrested. So
and one more question for the embryologist. Is that okay? What is your take on refreezing, sir? Do you mean suppose अभी हमने thaw किया embryos और patient का phone आया कि मेरी मासी गुजर गई मैं नहीं आ सकती हूँ. So what is your take on refreezing? Would you do a refreezing for the embryos?
Such
And
cases
what
we
is your
hardly
take?
come across, not where Masi, this thing,
हमारे
this
यहाँ
can
पे बहुत
happen.
आते
Because see, earlier, when we used to get lots of oocytes and all, then lots of embryos, then we decide, okay, we'll do blast. So we'll know, okay, then less number we can freeze. But if we get more blasts or more embryos, blast we freeze only one on one leaf.
Right.
And if that we'll just thaw it, if that is fine. So even if that lady is not able to come and all, we do a refreezing and
That
it
is
has been
okay.
working well.
The embryos don't get affected. I mean, if you refreeze
No, we have
them.
seen it is working very well.
Thank you, thank you.
So with this patient, I think poor responder is one of those cases, and this time where we are now again, going back to the basics, fresh transfer, day 3 freezing, day 3 transfer. Well, anyways, so this case, so I like ovarian rejuvenation. I'm not propagating it. There are enough articles to, of course, support it. Some say it's not useful. Koi harm nahi hai. We did an ovarian rejuvenation during the pickup. Because we got only 2 eggs, we decided, chalo, aaj, because she was from Mumbai, of course, we did an ovarian rejuvenation in the same sitting, and we sent her home, counseling that we'll do another pickup again. 60 days, gave her all the masalas and pre-treatment. So I am a fan of testosterone gel application for poor responders as a pre-treatment. If you have time, of course, as Dr. Vaibhav has pointed out, along with DHEA. So we gave her the treatment, and then she came back after 60 days. It could just be her luck, time, a different cycle, n number of reasons, but we got 6 eggs this time, 5 fertilized, again froze all day 3, 5 embryos on day 3. And then, of course, the patient was taken for transfer and FET was done. Something controversial, people might like, not like. What I did in this case was, we thought the 5 day 3 embryos, I did a double transfer because I didn't want to leave the patient without a transfer. We transferred. We've had a big discussion about single embryo transfers, but we transferred 3 embryos on day 3, let the rest to culture. Luckily, we got 1 blast on day 5. On the same cycle, we also transferred a blast, and she has a single live intrauterine pregnancy, which was diagnosed by Aditi. This is Rinjal's case. She didn't know
nice,
that.
nice,
But
nice.
we did this in Baroda, and then she was nearer to Mumbai, so she came for a scan to Aditi, and she's doing fine now. So this was a case of poor responders, which is, as we know, the most common and the trickiest part right now in IVF that we are facing.
So I think because we are running short
Yeah,
of
so
time.
thank you panelists, thank
our
you so
esteemed
much.
panelists. You all were all very good. Thank you so much. And Dr. Sujay and Dr. Nabila, can you please hand over the mementos to our panelists?
Yeah, we would also like to thank Dr. Yuvraj, Dr. Aditi for the wonderful moderation. Thank you very much.
Sir.
Thank you, Sudesh sir. And we'll have a group pic also.
Hostess के बिना
Memento.
Hello. Thank you, everyone. Now we have next on board the onco panel, the gynec onco panel. We invite Dr. Bhushan Wani, my best friend and colleague from Tata. He is a practicing surgical oncologist from Dhulia, and he's come all the way from Dhulia for us. And we have an exciting team of cancer. This is all my tumor board team. Dr. Siddharth Nakshit, radiation oncologist, 21st Century Cancer Care Aveksha. Dr. Sandeep Nakshid, sorry, Dr. Sandeep Ishi, our DM Onco from Tata and now practicing in Nasik. Dr. Sanket Shah, MCH surgical oncologist from Tata, practicing in Bombay, visiting us every weekends. Dr. Ninad Kadare, surgical oncologist ex-Tata. These are all my batchmates and seniors from Tata who helped me over the weekends for all my major cancer surgeries. We have Dr. Pranav Desai, surgical pathologist, Metropolis Surat. Shanil Shah, core diagnostics, interventional radiologist for onco in Vapi. I'm lucky to have, when I started in 2012, we had no facilities in Vapi for onco. And today we have Shanil with his core diagnostics and helping me with CT scan reporting, MRIs, interventional CTs, interventional ultrasounds. And these are the gadgets that we need for detecting cancer at an early stage. So we have Shanil here, we have a pathologist, and this is what we do every second and fourth Saturday at Vapi, a surgical oncology tumor board meeting. So in a small place also we are doing the best and ethical practice for 21st century cancer care. So we have our full-fledged 50-bedded cancer hospital at Vapi, where the present live transmission was going on, the venue for the live transmission, and this team meets every second and fourth Saturday and screens every patient, poor or rich, that comes to us, is screened through a tumor board, and we decide and write and type and give what is to be done, chemo first, radiation first, or surgery first, or palliative care. So all these facilities we have got to a small place like Vapi, and over to Bhushan, will go through the complete gynec oncology. We as gynecologists have very little knowledge about cancers. कोई भी cancer आता है तो जल्दी जल्दी भिगा देते हैं हम लोग. So that's what my mom also used to do before I came to Vapi. कि जल्दी जल्दी biopsy लेके भेगो, टाटा जाओ, इधर जाओ, वहाँ जाओ. And that's our favorite hobby of pushing the patient out. So let's at least have a basic knowledge, because mom had cancer and we know that I know personally how it is to have a cancer in the family. So I would want all the gynec delegates. We welcome Dr. Jigna Garasya. She is ex-GCRI gynecologist, specialist in colposcopies and diagnostic preventive cancers in our department. So this is an esteemed panel. Over to Bhushan. He'll take care of you. If there is any problems, we are there. We both are the moderators. Yeah.
Thanks, Akshay. First of all, I thanks my all panelists also, and but obvious audience, because I know we are out of the group.
Just a minute. We have Dr. Rajesh Rohit. Yes, gynecologist from Silvassa, a very dear friend to me, and he was the first gynec I met when I came into practice in Vapi, and he's a practicing gynecologist in Silvassa, an amazing person, and he's the president Silvassa OBGY Society as well. So, Rajesh ji, एक minute.
Jackson, please put a chair.
Yeah, it's here. It's there.
Chair.
Good. I'm a little glad that we have taken some two gynecologists in our team, so I think you guys will not get bored with all the surgeons and physicians. So first of all, what me and Akshay we have thought, we'll try to cover the basics for you. We are not going into any clinical trials, randomized trials, because I think as a gynecologist, during your IVF treatment, sometimes you might face any patients or sometimes in routine practice. So you should be well aware of these things. That's why I'm covering this.
Just a small announcement. Can somebody have the AC on first? One. And two, after 40 minutes, this panel, we have an amazing Dr. Navneet Meghon with 4 amazing cases starting exactly at 3:30 in the other hall. So we have cosmetic gynecology workshop with 4 cases, live demonstration for the first time ever, live transmission. So you can have a nice experience of Dr. Navneet's surgeries.
So as we are going, so it's a routine case, 32-year female, 2 full-term normal deliveries, regular periods, presented with the gynac OPD with the abdominal pain, feeling of fullness and a little bit lump in the lower abdomen. On examination, we found it's a soft, non-tender, mobile cystic mass in the lower abdomen reaching up to umbilicus. And per vaginally, yes, there was a mass in POD. So my question, first of all, to gynecologist, what you will be doing now, imaging-wise?
See, in these patients, she is 32 years old and she has a mass. So sonography is already saying it's, I think, have you done sonography? No, na?
I have done investigations, but I am just, what you, in imaging modality you will prefer? Ultrasonography?
MRI.
Upfront MRI you want to do? Okay. Dr. Ninath, what's your opinion as a surgical oncologist if patient comes to you directly?
So if it is a mass, before imaging, actually I would prefer doing some blood tests.
Perfect.
So,
first of all, we directly jump to the ultrasonography. I know majority of gynec and obstetricians, you are well versed with ultrasonography, but rightly said, tumor marker is really important factor. I'll go to next. Amongst tumor marker, I think we have Dr. Desai sir. Here, there is a bunch of tumor markers. We as a surgical oncologist sometimes see the patient, irrespective of primary pathology, hold a bunch of tumor markers is prescribed. So Dr. Desai, can you just enlighten which tumor markers are more important, in particularly in ovarian mass history?
So, hello, yeah. So, many times I get cases for intra-op frozen. Patient is young, ovarian cyst looks mostly benign, and they inform me at night that tomorrow morning we are taking. And I ask them what tumor markers they have done. So, mostly only CA125 is done.
Yes.
And actually it covers only 1 or 2 tumors. And especially in this young lady, it may not be required, because if it's a solid mass or solid cystic complex mass, then probably you would go for germ cell tumor markers like alpha-fetoprotein or beta-HCG. Again, if it's a multicystic mass with a mucinous imaging feeling, then you should go for CEA. In fact, even CA 19.9 is very important. Again, if it is very solid, you may go for inhibin B. So, lot of these are actually the better ones, which really help us. And all these should be done depending on, again, if radiology is done previously, you can exclude some of them. Otherwise, depending on age, CA 125 CE and this alpha-feto beta-HCG.
Yeah, sure. Very right, sir. Dr. Sanket, what is any relevance of 15.3 have you encountered, particularly with the ovarian mass history?
15.3 is usually used for breast cancers.
Perfect. So I'll give one just clinical experience. In my experience of last 5 years, I have found 2 patients who presented with the ovarian mass. All tumor markers were considered normal. Patient was planned for typical laparoscopic retrieval of the tumor. The clinical examination of breast was missed by everyone, and 15.3 was randomly done because the blood work was done in some health check package, and those guys have done 15.3 and it was raised. So just a day prior to surgery, that report was screened by physician while giving fitness, and there is that question, and fortunately the lump was found in the breast. So sometimes please do, whenever there is ovarian mass, please do examine the breast also. Sometimes there is a synchronous primaries, or there can be a breast primary going into ovary and patient is landed with you with the ovarian mass as a primary presentation.
Bhushan, I would like to add one more in this, especially the case since you have presented is 32. So in them, we always do HE4 also, human epididymal antigen 4. That is something, because it actually helps you in deciding with Roma whether it is
very true, very true.
Positive or negative.
So back to case 1, as in algorithm, first ultrasonography was done. It was a 10 by 13 centimeter complex cystic mass. So, but obvious that as tumor marker was requested, it was 543. It is significantly higher. So that's why the next investigation modality was CECT, which showed a large cystic mass with solid component and calcification, which was indenting into the bowel loops as well as the ureter. So what would be the next plan? Will you do any more imaging, or will proceed with the further surgical plan, or whatever the next plan? Anyone from panel? Nina or Sanket or even Jigna madam?
So usually for completing the med work, I always even do the thorax CT scan on such patients. And other than that, most of the things are covered. We don't need to do anything further other than, because looks like a ovarian mass with a CA125 raised. And if CA, CN19 and other tumor markers, AFP, beta, HCG, LDH are normal, I would consider this as epithelial ovarian neoplasm, more like.
Unfortunately, none of the other tumor markers were done in this case. So now, as the patient was planned for the surgery, so definitely we are in the era of laparoscopy. So first, putting a scope is the best option. So laparoscopy, Dr. Ninath, can you enlighten us what is the exact role of laparoscopy in ovarian masses?
So in any a diagnosis of ovarian masses, it is definitely helpful. If you have a proven borderline ovarian tumor or a germ cell tumor, it has been shown that you can do the entire surgery by laparoscopy also, provided you harvest all your specimen in a retrieval bag. There should be no spillage, there should be no rupture of the cyst. So laparoscopy can be used in that also. And then if you have an advanced stage disease, laparoscopy helps in the staging, like the PCI calculation and operability also.
Yep, very true. The laparoscopy has a significant important role in a diagnostic, irrespective of patient stage of the ovary. In the today's era, the concept is putting a scope, do a staging laparoscopy, document whether if it's a resectable, yes, we go ahead with surgery. If it's not resectable, at least it helps in doing a biopsy. As well as sometimes I'll consider in the next case. So, Dr. Desai, can you help us in how many times have you encountered about the frozen section, particularly intraop, and how is the accuracy about the diagnosing an ovarian tumor, particularly germ cell tumors, as the case was quite young?
So, as far as germ cell tumors are concerned, the diagnostic accuracy is quite good. But if it is a serous or a mucinous tumor, we have a hard time in many cases.
Yeah.
And sometimes we do have to say that it is at present like this, but after further sections are given, the grade may change, or from borderline it may become malignant. That does happen. Though we do take care that we sample the solid areas more often, the complex areas or honeycombed areas more often, which are more likely to show such changes. But in those cases, sometimes it's dicey. But in germ cell tumors, we are reasonably sure about the accuracy.
Okay. So, regarding the definitive surgery, Jigna madam, regarding the laparoscopy, if the patient is, as this patient was quite young, so what you feel the fertility preserving surgery is right or cytoreductive surgery is right? As patient sometimes preoperative tells doctor, आप तो भगवान हो, आप जो मेरे लिए सही समझोगे वो करिए.
Seeing the age of 32 years, yes, fertility preserving surgery may needed in her case, and two options are available for her. Seeing her CT scan report, I couldn't find any distant metastasis in her.
Perfect.
So we can preserve her ovaries, one ovary at least. We can remove the tumor, or we can induce her previously before the surgery short stimulation. We do the ICSI, we freeze the embryos, and later on we can think of if she doesn't have a distant metastasis.
Okay, Dr. Ninath, do you have some different opinion?
Yeah, so what I would prefer in this case would be like a complete staging cytoreduction, as I would call it. Remove the affected ovary, keep the normal ovary in place. Uterus, you don't have to remove in that, because even in an advanced ovary, if the uterus is not involved, you can preserve it. Infracolic omentectomy, peritoneal biopsies, and lymph node staging also, if there is a high suspicion of epithelial ovarian. So if I feel that, okay, my CT is suggestive, many times actually I don't prefer the CT, I prefer the MRI, because it gives a much better indication. And if MRI is highly suggestive of a malignancy, and if my frozen is conclusive, I would still do a fertility preserving surgery, because she is 32.
Okay, good. Dr. Sanket, you have some different opinion, or?
So I would discuss with patient also first, because she is 32 and full-term delivery, two already kids are there. So, and with my laparoscopic finding helping me more, If laparoscopy shows any more disease compared to the CT scan, then my things will change. But otherwise, if there's only a solitary ovarian mass, I would go and do exactly fertility preserving as told by Nina.
Yeah, so as a panel, including myself, we are of the opinion that yes, we should give the choice of fertility preserving as she's a young patient. Now I'll move to case 2. A 52-year-old lady presented with a history of abdominal distension, feeling of fullness, and frequent urination since last 3 to 4 months. Ultrasonography was 7 to 8 centimeter mass with the mild ascites, omentum nodularity, but obvious the panel of tumor marker was run. CA125 is 236, CA was normal, CA99 was 47, marginally raised. CT scan was ordered, which was suggestive of bilateral adnexus masses, and it was with the ascites, omentum nodularity, peritoneal deposits, and paraortic enlarged nodes. What next workup you expect, Jigna madam or Dr. Rohit? You can.
So MRI is the first one.
Okay. Yeah.
MRI, I'll suggest the first investigation to be done. And after that, because the mass is quite big, so we have to go for the surgical.
Okay.
Seeing the CT scan report, she has an advanced disease. So I would like to go with a CT or sonography guided biopsy, and depend upon that histopatho report, we can give her anterior chemotherapy followed by a surgery. Because in her case, it seems to be, actually it should be always a surgico-pathological staging.
Yeah.
But seeing these, we need to treat her, and if we select a surgery as a first line, sometimes we will be unable to remove the end mass. So it's better you do a biopsy, you give an anterior chemotherapy, reduce the size, and then you operate and you can give a chemotherapy later.
Okay. Radiologist Dr. Senil, how many times you have found a difficulty in detecting peritoneal nodules or omental nodules for reporting as a metastatic versus as a just inflammatory?
So if it's a frank peritoneal carcinomatosis or a metastatic disease, as in this case, it's not very difficult to detect on imaging. Sometimes we just come across very few nodules here and there, very tiny omental nodules. But with the setting of having a ovarian tumor and seeing these nodules, we would definitely raise a suspicion of them to be a metastatic. So if we carefully study the omentum and the peritoneum, it should not be very difficult to detect early peritoneal disease.
Sure.
Even with plain CT, of course, PET would give you even a small this thing.
So yeah, my next question would have been as a metastatic workup, Dr. Sanket or Dr. Ninad, what investigation you will prefer, doing a CT thorax or doing a PET scan upfront?
So in my practice, usually I do CT thorax abdo-pelvis, but even the PET scan, we find that sometimes we find unlikely mets in the bone or some other places. But usually, I have not seen much difference between the two.
Yeah, so guideline wise, yes, I agree with Sanket. The CT thorax and CT abdomen pelvis is quite sufficient for ovarian cancers. But if patient insists and if the facilities are available, you can go ahead with the PET also. Both are almost of the same importance. So FIGO staging, this is just a pictorial view for all of you, just to remember your gynac training, because based on those things, we plan the further treatment. Now, again go back to case 2. As Jigna madam has said, yes, it was an advanced disease as per se in the CT scan. So doing the upfront surgery would have been a little difficult question. Yes, probably that's right. But as per new current era's guidelines and the new facilities available, role of peritonectomy and HIPEC, sometimes we offer upfront surgeries if the patient performance status is quite good. So Dr. Ninat, can you enlighten us anything about the judgment between primary versus interval cytoreduction, how you do it?
Yeah, so in the case which you have shown, I would definitely try to attempt primary cytoreduction.
Perfect.
Because if you see the CA125 is not very raised. Actually, in these cases where the CA125 is not raised, they usually will be less responsive to chemo. So many times we have seen that even after chemo, the disease burden has not regressed significantly. So coming to the fact, if I'm doing primary cytoreduction, the first step I'll always do is a diagnostic laparoscopy. And in that, many of the scores options are available. Actually, many places, many doctors prefer using the PCI.
Yeah.
But if you ask me my personal choice, I prefer the Fagotti scoring.
Yeah.
Because what we have seen is the operability, the probability of able to do a complete cytoreduction I found was more better with Fagotti in my case at least. So I prefer using the Fagotti scoring. This Giovanni Alletti's complexity score is more or less the same, but my personal choice is Fagotti's. Maybe. if he
I
has any-
usually use PCI. I'm not aware, but in this case, my other thing which would be the general status of the patient, whether she is fit enough to go for such a major surgery at this stage or not. That is one more decision which will help us to take the decision. If she is nutritionally bad because of the ascites and other things, then I would go for the neoadjuvant chemotherapy first and then followed by surgery.
So many trials were conducted and the final conclusion was found primary versus interval cytoreduction. The results were variable of those trials. There was definitely some short-term advantage in the interval cytoreduction, but if you go with the performance status or overall survival, it was more of the same. So as a new concept, definitely we decide our decision based on the patient's performance status, patient's wish, what she wants to do it, and then we proceed. If the patient is fit, even if it's an advanced stage, we can definitely achieve the curable or maybe R0 resection during the surgery. Definitely lymphadenectomy. Why I have covered this particularly? Because majority of the gynec, they do very beautiful laparoscopic surgeries or maybe complete removal of the ovarian masses and everything, but unfortunately on histopathology it turns out to be malignancy, and then we are stuck whether the lymph nodes were removed or not, whether we should go now or we should not remove. So Dr. Ninad or Sanket, what is your opinion based on this? Should we do lymphadenectomy upfront in all the cases, or we should do it if the imaging is showing?
So if the imaging shows enlarged lymph nodes, definitely I am doing a lymphadenectomy, and it is never berry picking. I prefer systemic, though the data is mixed for that. Actually, in early stage disease, even if there is no lymph node seen on imaging, if you see the guidelines, stage 2B, up till stage 2B, I will always do a lymphadenectomy, because almost 20% of these patients will be upstaged after the lymphadenectomy. So in both these cases, I would prefer doing.
Other thing is also on frozen, if I am told that it is borderline, sometimes when we have only ovarian mass, that is when we do complete primary cytoreduction, that is where I will be always doing the lymph nodes.
At least sampling you will be doing.
Yes, I will be doing in such cases.
Dr. Sandeep, how many times you have faced difficulties where the complete surgery was done, as Sanket has said, primary cytoreduction was done, lymph nodes were not addressed. Have you seen any change in the survival, or maybe DFS is increase or decrease based on the lymphadenectomy?
Yeah, definitely. See, if it is lymph node involvement, it is upstage and definitely merits for the chemotherapy. But if it's a surgery was adequately done, lymph node is not involved, and then if you see stage 1A or 1B, even in C, there is a little bit doubt whether you have to give adjuvant chemo or not. In that case, definitely survival. So it's again, if lymph node is not addressed, then it is very dicey whether it is what is the exact staging. So definitely it will be a.
So in a dicey stage, do you consider as an advanced stage, upgrade the stage and give a prophylactic chemotherapy in such patients?
No, if possible, I will send patient back to the surgeon, and if possible, again the lymph node dissection, rather than just blanketly taken as a, whether it is to up and give the chemo. If it is again stage 1B, so definitely, because if it is no spillage, nothing, so there is no role for chemotherapy. But it's again, then in that case, I want make sure 100% whether lymph node is involved or not. Obviously, if it is 1B, the chance of involving lymph node is rare, but still we should consider that one.
Okay.
Actually, this is a question from my side to you. When we operate and when we get a histopathology report, few things we have to observe. One thing is lymphatic and vascular invasion.
Perfect.
So here my question is, if we are seeing a lymphatic invasion and if we have not done lymph node sampling or a dissection, what is to be done? Should we upstage the disease? We should consider for a chemotherapy.
I think Sandeep wants to answer this question.
See, again, if you see risk staging, when the lymphatic invasion and all the things, it is considered as a high risk. But again, the guidelines is not very convincingly says when your no lymph node dissection was done. So my again take will be, if possible, lymph node dissection should be there.
Yeah.
You cannot take the call on lymphatic invasion.
So take home message would be diagnostic laparoscopy has a very prominent role, whether it's a local disease or it's advanced disease, for maybe definitive treatment or maybe for the complete. But the most important principle you have to remember is a R0. R0 is a complete removal if it's a possible laparoscopically. I mean, you have done a very nice dissection and specimen retrieval you have done in a pieces, either from vagina or from the endo bag. It's not justified, particularly for the ovarian tumors. Chemotherapy, Sandeep, just in brief, can you enlighten us what are the general side effects and how you generally give chemotherapies or how you decide?
Okay. If we stick to the ovarian cases, in ovary we usually say epithelial ovarian cases rather than germ cell. In epithelial ovarian cases, it is called platinum sensitivity. So it is a very platinum sensitive drug. So we usually use a platinum doublet, that is paclitaxel and carboplatin. And the side effect, like if it is a paclitaxel, then side effect will be your myalgia and peripheral neuropathy. That is most important. And carboplatin, if you use, then it causes hypersensitivity reactions after 3 to 4 cycles. So this is the most common side effect when we are specifically treating with the epithelial ovarian cancer. There are common side effects like hair loss, which will be a little less, or myelosuppression, which pertaining to afterward causes infections, and thrombocytopenia causing bleeding. But more important in ovary, we have to look for the myalgia, peripheral neuropathy, and hypersensitivity reaction for pertaining paclicarbo. So generalized making other things will be a little beyond the scope of this discussion.
Yeah, I mean, we are not going into detail. Dr. Siddharth, would you like to enlighten us any role of radiation in the particularly ovarian cancer?
Generally, ovary, we don't treat with radiation.
Perfect.
Only if it is metastatic disease or anything.
Yeah, so it's another take-home message for all my pretty gynec friends. Generally, there is no role of radiation in ovarian cancer, whether you left behind disease. If it's a R plus disease, either you have to go back and remove it or you have to treat with the chemotherapy only. Dr. Ninath, as you are expert, can you enlighten us a little bit about HIPEC and PIPAC? What are the concepts and...
Yeah, so basically HIPEC is a heated intraperitoneal chemotherapy. And now we have a randomized trial has happened which has shown a benefit for HIPEC in interval cytoreductions. And it is only done in those cases which were not fit for upfront cytoreduction, which has been evaluated by a surgical oncologist, a gynec oncologist. In those cases, they were not fit for upfront cytoreduction. R0 was not possible. In those patients, after NACT, if the disease regression is there, then patients can be posted for HIPEC. People have been doing it for primary cytoreductions. They have been doing it for recurrent, but the evidence is less. I personally also used to initially do it for recurrent ovary, but I'm pretty choosy, especially only if it's mucinous, I might consider doing it, but for serous epithelial, I don't.
Okay.
And PIPAC is a new kid on the block. It is pressurized intraperitoneal aerosolized chemotherapy. So it is more of a palliative treatment. So your patients who are not responding to chemotherapy, who have gross ascites, you can actually use PIPAC in them. And there's almost a 70 to 80% regression of ascites in such patients. In 10 to 20% of them, there is disease regression also.
Okay.
So just one point, can I put it before the endometrium starts?
Yeah, please.
Actually, because one of our case was young, and it might interest the gynecologist, that there is one thing that especially if the patient's menstrual history is not proper, you can often get endometriotic masses where the CA125 can go up till thousands also. On an average, in a year, we do 5 to 6 such cases where they've been referred to us as a ovarian mass, ovarian cancer, and in the final histopathology, it turns out to be endometriotic cyst. So the past history associated with MRI findings, I think, Doctor, you might be able to put some pointers on that. In such cases, MRI would really help, and especially both the cases with the MRI also not conclusive and the CA125 high, but with a bad obstetric history or a bad menstrual history, such patients you have to counsel them for the negative histopathology also.
Yeah, very true. So that's why what Akshay told us just starting the session, ki as a gynecologist, please don't get afraid if the CA125 is raised. There are many conditions where irrespective of diagnosis of malignancy, CA125 can be raised.
Yes, I want to add one more thing. Ki whenever you are suspecting a malignancy, CA125 should be in a thousands. When you are saying it at a borderline, it can be a early disease, it can be a benign disease. So always CA125 is high, it doesn't mean patient is having a malignancy. So you have to, and actually saying CA125 is not a diagnostic marker as an epithelial cancer. But we routinely use it in a follow-up. When you are treating your patient, you follow the CA125 level, whether your patient is responding to your treatment or not. That's what we were used to follow.
Very true, madam. Yes, madam. Yeah. Yes.
Roma index would be better than RMI.
Yeah, Roma is a more preferred index.
So HE4 and CA125 together, and then the Roma index would be better predictor than RMI. We've also seen a lot of, at least I know about 8 to 9 cases. One was a doctor's wife who had massive ascites and nodularity in the peritoneum. Ovaries both were mildly enlarged, about 4 or 5 centimeter. Not conclusive this way or that way, but the serum ADA was very high, and she was given AKT and she got well. CA125 was about 550. So tuberculosis in our country is also a very important cause of elevated CA125. Another thing which not many clinicians know, all these tumor markers in their higher ranges, different equipments, for example, equipment from Roche or Siemens or from Abbott, all three are very good, top of the line. But at the higher level, the difference between the values from the same sample would be 300-400.
Yeah.
So you may have 900 CA125 in one lab, 600 in another lab. And when you are following up, it is very important to stick to one lab. Don't change labs. If you don't get the desired result, say you have given some chemo, the fall is not as much as you are expected. The general reaction of a clinician is go to another lab. You know, this is not right. It is not according to what you in fact call up the same lab, tell I am expecting a fall. You recheck your value on same sample, on another sample, but don't change the lab. Sure. Especially for tumor markers. The difference at higher levels is very high. So even though both are standardized, both have good quality, still it is the nature of the antigen they use in the kit, in making the kit, which is different. So the values are different. So stick to one lab in all tumor markers.
Yeah, as a short of time, I will move to another organ, endometrium. So it's a 56-year female full-term, 4 full-term normal deliveries, postmenopausal result, presented with the spotting 3 to 4 episodes since last 2 months. Dr. Jigna or Dr. Rohit, sorry, can you answer? What would be the, sorry, I already given the organ. So, but what would you do the next step of investigation, or what things you want to do it?
Endometrial biopsy or ENC, and then MRI and the tumor markers.
Okay. So, imaging, Dr. Sainil, can you enlighten us for particularly diagnosing a endometrial, either maybe hyperplasia or maybe cancer, what imaging would be the best to diagnose? Because as now in majority of the cities, all these 4s are available, Even the PET scan has gone to majority of district places now. So which imaging we should prefer?
So if we are specifically looking for CA endometrium, I would suggest please directly go for MRI.
Perfect.
Why is that? Because, and specifically ask for a dynamic MRI. Because, when you want to see the myometrial invasion, whether it's, hardly less than 50% invasion or whether it's just confined to the endometrium, a dynamic MRI would definitely help to see if there is any breach, very early breach in the endometrium. So I would suggest MRI pelvis for CA endometrium.
Yeah. So
CT
generally
would not be so conclusive because it may just show endometrial thickening that you will find also on ultrasound. So MRI would definitely give you more information and probably help in treatment planning.
So majority of the centers, they found a midway where they do a MRI pelvis and CT cuts for the abdomen to rule out the lymph nodes in the iliac obturator group as well as in the retroperitoneum. So I'll go back to, same case, as the CA125 was also done, which was normal ultrasonography CT, I'll go directly to the CT. It was showing 2 by 2 centimeter enhancing lesion in endometrial cavity with minimal infiltration of myometrium. So as Dr. Senil has said, yes, CT will not differentiate whether it is exactly myometrium infiltration was how much. And that is a major deciding factor for deciding my clinical staging in stage 1A, B. So MRI is a preferred choice, but unfortunately it was not done here. So diagnostic biopsy, Dr. Jigna, there are now 3 modes available for making a biopsy. One is typical traditional dilatation and curettage, one was pupil biopsy and hysteroscopic biopsy. What is your preference?
I will definitely go with a hysteroscopic guided biopsy. Perfect. Because DNC is a blind procedure. Again, pupil is a blind procedure, but when you have a global, means endometrial hyperplasia, you will get a tissue, adequate tissue in such cases, and it's an office procedure. Yeah. So it's the easiest way. But when you have a small lesion, when you have a focal lesion, you may get a negative biopsy. So my choice is hysteroscopic guided biopsy for all.
Absolutely. Hysteroscopic biopsy is the gold standard, but if the office hysteroscopy procedure is not available, then even the traditional dilatation curettage can help you in making a diagnosis of endometrial cancers. And as a surgeons, yes, pipette biopsies can be done as an office biopsy also.
Just a minute. When you go for a DNC, there should be a fractional curettage. Means you have to take a endocervical curettage and 4-wall biopsy, 4 quadrant. Anterior, posterior, and both lateral walls. Means it's not a simple blind curettage. So always make it a point. If you have a hysteroscopy, obviously you should go with a hysteroscopy. But in a blind DNC, it should be a 4-wall biopsy.
Particularly my experience, because definitely I don't know how to do DNC. So I refer to my gynac, and it was a very early cancer. Gynecologist did very nice DNC. We proceed with the histopath, the proper radical surgeries, and final histopath turned out to be no viable tumor visible in the uterus. So dilatation and curettage can wipe off your whole tumor if it's a very early cancer, if there is no myometrial invasion. So sometimes you have to explain the patient and take a consent, because I face that problem for convincing patient that there is a possibility. So it is just what message I learn in my practice. So now surgery, Dr. Nina, can you again enlighten us what is the role of laparoscopy? See, I am not going into open because everyone knows the open is possible. Role of laparoscopy again here.
As you have mentioned, staging laparoscopy always is needed in ovary and endometrium. And we have data to support that in endometrium, laparoscopy is safe to do the entire surgery by
Perfect.
laparoscopy also.
Perfect.
So the entire hysterectomy, oophorectomy, lymph nodes.
Yeah, that was a definitive surgery. Like what we do as a definitive surgery in endometrium is a total abdominal hysterectomies. It can be done open or laparoscopy. We have to do sulfing oophorectomies if the myometrium invasion is more, if the more than moderately differentiated adenocarcinomas. Then in the lymph nodes, we remove generally iliac and obturator group of lymph nodes. But on the CT scan, if the retroperitoneal lymph nodes are smallly enhanced or there is a doubt, it is better to do sampling and omentectomy. Do you prefer doing omentectomy in every patient or you choose based on the pathology?
On the pathology, only in serous endometrial, if I suspect, if I have a available diagnosis of serous endometrial, then only I'll do. I don't do in each and every case.
Okay,
actually.
very
So as we have in endometrial CA, there are two types, type 1 and type 2. Type 1 is endometrial adeno CA, which is usually most common one. In that patients, retroperitoneal and omentectomy are not always required. Only when you find there is a disease or anything in the retroperitoneum or omentum, that is the only place you do. But in other type 2 histology, like serous and other types of endometrial CA, that is when the retroperitoneal and the omentectomy has to be done, because they behave sometimes like a ovarian tumor, and they spread in that way.
Okay. Dr. Desai, can you enlighten us what exactly differentiation of two types of endometrial type 1 and type 2 pathologically, because that is the most important for deciding my extent of surgery.
So on histologically, the type 1 which he says, the common one, the endometrioid type, resembles the normal endometrium in the type of the glands which we see under the microscope. So even if it is poorly differentiated, which is rare in, basically endometrioid are generally grade 1 mainly, or grade 2 sometimes. Grade 3 are rare, but even when they are grade 3, they don't look as bad and as angry as serous carcinomas. So the serous carcinomas or the other type are just like the ovarian high-grade serous, not the ovarian low-grade serous, but like the ovarian high-grade serous. They are very angry looking. It takes you just 1 minute, or even a novice will tell you that it's a malignant tumor, but because it's very angry looking under the microscope. And that angry look gives its angry behavior, which is why Dr. Ninad wants to do a sampling in such cases, because they are inherently very aggressive high-grade tumors.
Dr. Siddharth, now I'll give you three dilemmas, particularly what we face as an oncologist in our OPDs. Majority of the times, the diagnosis of endometrial tumors was not done preoperatively. Patient has upfront underwent a TLH or maybe open hysterectomies, or maybe in some peripheries, vaginal hysterectomy is still quite common. So if the vaginal hysterectomy patient is done, histopathis turns out to be well-differentiated adenocarcinoma, less than 50% of myometrium, no lymphovascular emboli, nothing mentioned about the lymph node status. We don't know preoperatively whether they were enlarged or not. What would be our adjuvant plan?
Because here it is a well-differentiated stage 1A, no LV, so there are very less chances that the lymph nodes would be involved. So if the lymph nodes are not addressed, that is okay for me. But here it was a vaginal hysterectomy. If it was an abdominal hysterectomy, we would have just observed this patient.
Perfect.
But because of vaginal hysterectomy, I would at least go for a brachytherapy, boost to the vaginal vault and the proximal half of the vagina.
Okay. Dr. Sanket, is there any role of going back inside, open or laparoscopically, and take care of the both ovaries? And we don't know about whether fallopian tubes were removed or not, or for the lymph node sampling. Is there any concept of that, or you will directly refer patient for brachy?
So I will again do the workup, like if there is no pre-operatively CT scan or MRI done, I would like to do that to see the lymph node enlargement and anything done already, whether is any enlarged nodes. And if that is there, then I like counsel the patient for the completion surgery, like bilateral surfing oophorectomy with lymph node. But if there is nothing on the scans, I sometimes even, and most of the patient in rural or tier 2 areas, they deny doing the second surgery just because there is nothing seen on the scans.
Yeah.
Then we have to explain them that this is the scenario and we don't know exactly the stage. And such patients I send them for the radiotherapy. But otherwise, I would like to do the completion surgery with BSO and the lymph nodes at least.
Okay. Relook CT scan generally, Dr. Senil, how many times do you recommend? What is the ideal time when we should do it? If the patient has undergone a vaginal or open hysterectomies, and as a now oncologist, we are asking, I want to do a CT scan. So what is the ideal time when we should do it?
There is no ideal time, but generally 4 to 6 weeks is a good time to assess. Primarily, post-operative changes have subsided and probably first line of chemotherapy has gone. So probably a 6 weeks time is a good time to judge and then probably take a call from there.
Okay. So now another case where the laparoscopic hysterectomy with bilateral sulfonylureectomy is done. histopath turns out to be poorly differentiated adenocarcinoma, more than 50% of myometrium is involved, reaching up to serosa, lymphovascular emboli was present, and both ovaries are normal. What is the adjuvant plan? Dr. Ishi? You will upfront go for the adjuvant chemotherapies, or would you like to do some, your surgical colleagues help?
Again, lymph node status we should know because more than 50% myometrium is involved. So scan, PET, if possible PET, or at least MRI. And then if it is a lymph node involvement, surgically we can remove, it's okay. But if we can't remove, but if the imaging shows it's involved, so then ideally advise for the surgery. If no, then definitely roll for the adjuvant chemo followed by radiotherapy. And if it is a lymph node is not involved, but then again we have to decide about the risk factor like age, the lymphovascular invasions and that thing. In that basis, then again there is some role for adjuvant chemotherapy also in lymph node negative status also.
Okay. Dr. Siddharth, you will radiate this patient?
Yes, if, as sir said, if the lymph nodes are negative, then we have to go for external RT followed by brachytherapy. Both will be given for this patient. Also, age is very important. If the age is more than 60, that again becomes a risk factor here.
So take home message for all of you is again, for any endometrial or maybe pervaginal bleeding in a postmenopausal lady, as you please proceed with the first hysteroscopic diagnosis, make it sure whether it's a malignancy or not. If it's a malignancy, then please do imaging, or even if it's not malignancy, on your hysteroscopic biopsies, please do some good imaging, because even if the status of knowing lymph nodes in iliac, obturator or retroperitoneum is very important for deciding us as a adjuvant treatment. So any good imaging preoperatively if there is no documented malignancy. I'll move to next organ cervix because we are short of time. So 34-year female, para 1 and presented with the menorrhagia since last 6 months, multiple fibroids on imaging, screening as standard done with the HPV which shows the HPV 16 is positive. On pap smear it's ascus. Dr. Jigna or Dr. Rohit, what would be your next step?
Seeing the history and pap smear, my first question, I will contact my pathologist and I'll ask him what do you mean by ascus? Yes. Atypical squamous cells of undetermined significance favoring benign or a malignant.
Very so true.
That is the first thing. And second, I will post her for a colposcopy. And depending upon a colposcopy findings, may do a colposcopy guided biopsy. And according to the report, we'll treat.
Sure. I'll take that question to Dr. Desai later. I have something for him also. So colposcopy, yes. Can you enlighten us? Colposcopy, what exactly you do?
See, colposcopy is a microscopic examination of a cervix, particularly transformation zone, because any cervical malignancy starts from the transformation zone. So whenever we are posting any patient for a colposcopy means we are inspecting the transformation zone. Ideally, it is to be done in a follicular phase because as you know, transformation zone comes out in a estrogenic influence. You are doing in a luteal phase, you will be unable to see the entire T-zone. Colposcopy, we apply several, we do a test. One is a Schiller's test, second is a acetic acid test, and we see the vessels. And seeing the result of all these 3 tests, we conclude with the report. Whenever you see the any colposcopy report, first and very important in your report is whether it is a satisfactory or unsatisfactory. Satisfactory doesn't mean it is normal and unsatisfactory doesn't mean it is abnormal. Satisfactory means you have seen the entire T-zone. If you have missed, you are unable to see the T-zone, you cannot say that my colposcopy is normal because it's a microscopic disease. If patient is having and you have not checked that area, you may miss the diagnosis. So first thing is satisfactory and unsatisfactory, and second is the impression, whether any changes. You want me to elaborate in this?
No, I think. So on colposcopy, the gynecologist underwent with the large loop excision of transformation zone, as madam has rightly said, and final histopath turns out to be CIN3. Margins are free. Dr. Desai, can you just enlighten us what is CIN 1, 2, 3? and how pathologically it is different?
So,
for audience, I have just given you one figure.
by definition now, WHO new classification says that all CINs are HPV related.
Yep.
100%. They have to be HPV related. If you have CIN and HPV is negative, then either repeat HPV or it is not CIN, it is something, a mimic.
Yeah.
Right? So your HPV testing should be good, number one. Number two, now CINs, or what they prefer to call as squamous intraepithelial lesions, the new term, they have now divided into two tiers, LSIL and HSIL. So CIN 2 and 3 previously, what we used to say is both now HSIL.
HSIL.
And the low grades are LSIL. LSIL is important because they are generally due to the low risk HPV types, and 90% of them regress on follow-up. They go away.
Yeah.
So you just need to follow up and ensure. They may not go away if, because the rate of infection is so high in the world, that they may get co-infected with another HR serotype and may have malignancy later on. But if it has the original one, the patient the lesion may regress. CIN 2 and 3 are more aggressive. Normally on a biopsy, if the dysplasia or the bad cells are limited to the lower 1/3 of the epithelium, it is so the lower 1/3 of the epithelium, if dysplasia is restricted, it is LSIL or CIN 1. CIN 2, it is 2/3, and CIN 3 is full thickness high grade dysplasia. Okay. So that is the three different types, and mostly the high risk HPV types are responsible for 2 and 3.
Yeah. Okay. Now I'll move to next case 2. So she is a 30-year female, presented with a white discharge and bleeding since 2 months. On per speculum, it's a 3 by 1.5 centimeter ulcer proliferative growth at external os, both parametrium, foraces, vagina is free. Dr. Sanket, what you will prefer, scrap, pap or biopsy?
Biopsy.
Okay. Dr. Jigna, what is your offer? Dr. Rohit, you want to say? Okay, so everyone is agreeing only doing a pap smear is inadequate diagnosis. So this patient underwent imaging, which but obvious because generally majority of our patients, they undergo with the algorithm of doing first sonography, then CT, then if required MRI. So patient's CT scan was showing 2.7 by 1.2 centimeter tumor and clinically local disease. Dr. Ninath, would you want to order MRI in such patients to add something more?
Actually, in cervix, if the clinically parameter are free, I won't need.
Perfect. So in the local disease, there is no doing even, because clinically, as per the old concepts, not even doing a CT scan is justified in local cervical tumors. But nowadays, CT scan has come in the guidelines. I think Dr. Sanket wants to add something.
My preferred choice for these patients are also usually MRI, because the parametrium and other things are seen better on MRI compared to CT scan.
So that's what, if it's based completely on clinical judgment, because cervical diagnosis as per FIGO, it's a clinical diagnosis, because your clinical stage, so with experience you can differentiate whether the parametrium is inflamed, indurated or involved. But obviously that requires a good experience. So treatment. This is for audience again as a pictorial, because I have to cover everything. So as it's a stage 1A, Dr. Ninath, would you like to say something about what we do in generally stage 1A and stage 1B too?
I prefer, like in 1A, I would do a simple hysterectomy with lymph node. But 1A2 onwards, I would prefer a radical hysterectomy, at least type 1, type 2.
Dr. Sanket?
So in 1A, which is microscopic disease, that is where the simple hysterectomy is more than enough. You don't require anything more than that, other than the pelvic lymph nodes. But other than that, any stage more than that, always type 2 or type 3 radical hysterectomy, as we commonly know as Wardheim's hysterectomy, and the type 3 with a nerve sparing. That are the commonly one done.
Is there any difference of a surgical treatment for CIN3 versus stage 1A1?
So in CIN, you don't require the lymph nodes.
Yeah.
and this one requires the lymph node dissection.
So that is a probably major misconception in CIN. People feel doing a simple hysterectomy is justified, which is true, but for documented cervical cancer, lymph node dissection is must because to rule out about a microscopic metastasis.
Excuse me. I want to add one thing. When we are having a CIN diagnosis, malignancy is different.
Yes.
CIN doesn't mean patient is having a malignancy.
Yes.
CIN1 is most of the time it's because of infection. So we should, such patients don't need hysterectomy. We need to treat infection and we have to follow them regularly.
My suggestion for the audience was for CIN3, it's not a documented malignancy, it's a pre-malignant conditions. For stage 1A1, it's also microscopic disease. So sometimes people do feel, I'm not talking about a oncologist practicing. Sometimes people do feel if on histopathology it turns out to be stage 1A1, is it just doing a simple hysterectomy is sufficient or not? So this is a pictorial diagram. What is the difference? Dr. Ninad or Sanket, can you just enlighten what exactly parameter, what is the difference between radical hysterectomy and simple hysterectomy?
So in simple terms, when we are doing surgically, when we do go along the surface of the uterus, that is a simple hysterectomy or the nth one. In radical hysterectomy, when we do for the CA cervix, we take from the origin of the uterine artery, and we take that uterine artery, all the parameter of the soft tissue which is there along that, we take from lateral to medial to the ureter, and we lateralize the ureter completely, so that whole of the tissue which is there has to be taken from that area.
Okay.
I would like to add one point is like cervix, mostly we have squamous cell, and usually the mode of spread is lymphatic emboli as well as permeation. So most of your lymphatics are going to lie in that tissue which extends from your uterus to the uterine artery. That is why that technique has to be there to isolate the uterine artery at the origin and take the entire parametrium towards the specimen.
One new concept for all of you, ovarian transposition. Do you recommend doing an ovarian transposition in all the times if the patient is definitely young patient, or you knock it off ovaries?
No.
I'm talking about premenopausal young patient of around 35-40.
All cervix cancers, I will do uterine transposition. Ovarian
very
transposition,
good.
sorry.
Yeah, so no need of removing ovaries in cervical cancer if it's a premenopausal lady. Is there any another role of ovarian transposition even in an advanced disease?
Yes, because you're going to use radiation in them. So they often may fall in the radiation zone, and radiation can destroy the follicles. So in them also you'll need to do that.
Okay. So now case 3, 57-year-old postmenopausal presented with a bleeding and hematuria. On per speculum, it's a 6 by 4 centimeter large mass involving external os, obliterating both the fornices, right parametric infiltration. Sorry, by mistake, it's both para is written free. So biopsy was moderately differentiated squamous cell cancer. On ultrasonography, on CT scan, it's enhancing lesion of 5 by 4 centimeter, same as clinical finding. Parametrium is involved with moderate hydronephrosis. Indistinct fat planes with posterior wall of urinary bladder. Rectum is free. Multiple lymph nodes at iliac and obturator group. Is there any role of PET scan? Dr. Senil, would you like to tell us on PET, will we getting anything extra apart from this in particularly abdomen? I'm not asking about a systemic status. I am asking about particularly about the cervix.
Local disease, there's no role of PET, I would say. Unless it's for staging, you want PET of the whole body. Local disease, say if at all you would want any other investigation, it would be MRI. Just as, rectum is free, but at times we see very early lesions with the anterior wall of rectum. So, MR would definitely help in giving further information, but not PET.
I think this case will go for radiation. Dr. Siddharth, would you like to add some more investigation, or you will proceed with this? This data is sufficient for you, or you want to do some more workup?
No, only biopsy report will be sufficient, and a chest X-ray or a CT thorax.
And I would like to do a cystoscopy before starting anything.
So, what is the role of doing cystoscopy as well as a prophylactic DJ stenting in such patient? Dr. Sanket, as you enlighten, can you give us?
So basically, two things. As there is a hydronephrosis, so patient, if they are more risk of getting that ureteric involvement, so DJ stenting will be done prior. And cystoscopy will give me information about the bladder wall involvement. If there is a bladder wall involvement and we start with the chemo radiation or radiation, as they can develop a fistula. So that is one of the things which we need to take care. Hence, in such cases, I would like to start with the chemo first rather than giving a radiation.
So now Sandeep, can you just enlighten about the NSCT, where you will start neoadjuvant treatment?
Yeah, as we are actually discussed, cystoscopy shows bladder muscle invasion. In that case, to avoid the fistula is the only indication for the NACT in the cervix.
Is there any role of neoadjuvant chemotherapy, particularly stage 2A, 2, where the tumor is little bit more than 4 centimeter? I mean, my clinical examination, it's around 3.5 centimeter tumor. I am a surgeon, I want to operate, I don't want to radiate the patient. But unfortunately, on CT scan, Dr. Saini gives it's a 4.2 centimeter. So is there any concept of reducing tumor size by giving chemotherapy and push that patient for surgery?
No, if you see the recent data published by our Dr. Sudeep Gupta in the ISMO, that there is no role of NSCT in surgery, followed by surgery versus radical CTRT.
So in oncology, irrespective of organ, the main concept is the first staging at the time of diagnosis is considered as a final staging. It is not, the staging is not made based after the response of chemotherapy. Now in this patient, is there any role of surgery or radical radiation or concurrent chemoradiation? Dr. Siddharth, can you enlighten us what you will prefer?
Here, because the tumor size is more, ideal would be concurrent chemoradiotherapy if the patient's general condition permits. So that would be the ideal.
If the bladder is free.
Yeah.
If the bladder is free.
In radiation, what is EBRT and brachytherapy or both?
So for cervical cancers, EBRT and brachytherapy both are required because the EBRT is external beam radiation therapy, which is given by a linear accelerator, which is similar to a CT scan or a MRI machine. Brachytherapy is also required because we have to give some dose as an internal treatment because the curative dose for cervical cancer is around 90 to 95 Gray. Gray is the unit of radiation, and the tolerance of bladder and rectum is quite low. So around 75 to 80 Gray is the tolerance. So we can't exceed the tolerance, otherwise the long-term and short-term toxicities would be more. So a mix of both external and brachytherapy is important for this.
Yeah, thank you. Now, last slide about the prevention. Particularly as we are seeing a human papilloma virus infection is rampant and it's quite common in India still today, particularly for the cervix. So, Dr. Jigna or Rohit, can you just enlighten us about the cervical vaccines? What is your say? Because majority, I think 80 to 90% of patients, they were going to come to you instead of us.
Cervical malignancy is a disease, it is actually preventable. But we are getting more patients because of lack of awareness in our country. So we should recommend vaccination to all patients. And I think as per government guidelines in 2023, we are having our own vaccine, and government has declared that it's going to be included in a school immunization program. So each and every girl is going to be immunized for a cervical malignancy vaccine. So definitely we should vaccinate. And in a routine immunization schedule, pediatrician has already started giving it. Those who are educated, they are demanding. Those who are a reproductive age group, we should give vaccine till the age of 42 to 44. For a Gardasil, Cervarix is not available. It is a bivalent, and Gardasil is a quadrivalent vaccine. Nowadays we have only Gardasil vaccine available. If you give it before menarche, single dose is enough in a girl. And in a reproductive age, we have to give 3 doses, 0, 2 months and 6 months.
Perfect. Yeah.
And of course, pap smear is must for all female after age of 35 for prevention.
Yeah. So thank you very much, all of you. I think this would have been something like a caffeine dose for your IVF session. It is absolutely out of the box. Yeah. Thank you very much.
I have a question for the clinicians. So the last classification of cervical cancers by WHO classifies all cancers into either HPV positive or HPV negative, even the adenocarcinomas. So, but I don't see many cancers being tested for HPV after I give the diagnosis. So is it necessary? Does it change anything? They say that HPV negative cancers, even squamous or adeno, are more aggressive.
Treatment wise, I will say in another end, it is a treatment changing in oropharynx. In cervix, the treatment will not change. But oropharynx, definitely the treatment change.
Right, right.
So I thank you all my panelists for accepting all my shooting questions. Thank you very much.
Thank you.
Thank you everybody. And it was a nice, big, important panel. And I request Dr. Pooja Nadkarni to please give the mementos to our panelists and our moderator. Moderator Dr. Bhushan Vani. Bhushan has been a friend since a long time. And thank you, Bhushan, for moderating such a nice, exhaustive panel with all the important questions in Oncogynac. He's lost. He's in the other hall, actually. Thank you, Dr. Rohit. Thank you, Dr. Sandeep Ishi. Thank you, Dr. Ninad. Thank you, Siddharth. Thank you, Sanket. Thank you, sir. Thank you so much. And thank you, Dr. Chanel. So now Pujudi, one group photo. Now after this small video by GE, we have a video session where our ex-fellows will be presenting their master videos, short master videos, 8 minutes each. So there's just a 2 minutes break. Stop it. Yes. Thank you so much. And now we have Dr. Savan Shah, right? Dr. Savan Shah. He'll be presenting. So Dr. Amit Kamath, you can please show your video. And after that, Dr. Amit Varia, we have your video presentation. I hope you have given the pen drive to the IT people. So Dr. Amit Kamath is consultant OBGYN practicing in Mumbai, and he's been our ex-fellow at Nadkarni Training Academy. And I welcome Amit to show your video, your master video in how I do it.
Good afternoon, everybody. My video, I have made a collection of small videos about bladder dissection in cases of TLH. So I start from cases which are very easy to something which is very difficult. This is basically for beginners who have just started doing TLH, and for them it will be very helpful. So this first case is a simple case of bladder dissection. This lady had previous to normal deliveries with adenomyosis. So the first step is you have to cut the UV fold. Once the UV fold is cut, you lift it and gently you try to push the bladder down. Whenever you see these bubbles or champagne effect or what we call loose this areolar tissue, we just push it. We do blunt dissection. And whenever there are cases where there are strands which are not moved easily, we go for sharp dissection. So always first we do central dissection, and once central dissection is done, we go towards the bladder pillars. The bladder pillars are always vascular, so you have to be careful and more gentle. So now this central part is done here. So I'll lift the UV fold towards the left side, and the bladder pillar, it gets delineated. And then I slowly dissect this left side bladder pillar, and then I repeat the same thing on the right side. Dissection of bladder pillars is very important because it makes your uterine stump very prominent, and you can easily cauterize it while cutting. And also it keeps the ureter away. Now I have gone to the right side of the bladder pillar. So this first case was a simple case. It finished in around 1 minute 15 seconds. So this is done. Now and see the stump here. The stump is nicely graded. This is a case of with a lateral window technique. She had a previous 1 C-section, and the aim of lateral window technique is we have to stay as lateral as possible while cutting the cornuals. When we are cutting the round ligament, we stay lateral. We enter the paravesical space. We should not be medial. We should not be touching the uterine vessels. And we go below the scar. Once we go below the scar, we get a virgin plane where the bladder is not adherent. And now, as you can see, I've got the plane between the cervix and the bladder. And from here, I've just dissected the bladder down. You will understand now. Can you see the lateral window created here? So once the lateral window is created and the bladder is pushed down, only thing what we have to do is we have to dissect the fibrotic scar that is above it. This case was simple. This was only a previous 1 section. That's why I got the plane easily. But in all cases, for a lateral window technique, it is not so easy to get the plane. Especially in previous 4 LSCS, it is not that easy. And very important rule is you have to stay away from the uterine vessels, because when you are creating the lateral window, if you happen to lacerate the vein, then it starts oozing and the whole plane is gone. Then it becomes very difficult to find after that. So now this is almost done, this case also. As you can see, the bladder is nicely dissected. Only thing left over is to cut the fibrotic area here. And it's done. Next case is also a case of lateral window technique, but in this case the bladder was, it was previous 3 LSCS. The next case, it will come now. Yeah, this is done. This is also a case of lateral window technique, but can you see the bladder here? Bladder is almost indenting into the uterus. This is quite adherent. This was previous 3 LSCS. Here also I tried my luck, and luckily I got the window later on. So what we have to do is, again, as you can see, I'm trying to open the broad ligament, the anterior and posterior leaf of the broad ligament, and trying to enter the paravesical space. So the marker which you have to always look for is the uterine artery. You have to stay away from the uterine artery, but you should always look where it is. And once you get the uterine artery, you should stay anterior to the uterine artery, and you will always get a plane. Can you see here? there is uterine artery, and just above that, I have got the plane between the cervix and the bladder. And after that, it is almost similar. Once you get the plane, you should not leave it. Here only a blunt dissection is enough. You should go below, and you can just dissect from left side to right side. So this case is also almost done. I'll go ahead. This is a case of bladder central dissection. Like I said, when we encounter cases with previous to LSCS, sometimes we can go by a lateral window, but nowadays many people just go by central dissection. This case, this looks a bit scary, but it is actually quite safe. Only thing what we have to remember is we have to go millimeter by millimeter, and we have to just cut the scar area. Now with the harmonic, if you can see, I am only using the tip of the harmonic. And once the scar area is incised, you immediately reach the plane. Like I've already reached the plane on the right side. I repeat the same thing on the left side and in the center. And we can easily get the plane here. So this is also a safe method. Only thing it requires a bit of practice, and you should have good control over your harmonic or whatever instrument you are using. And another rule is whenever you have doubt about the plane, you lift the bladder. Don't just lift the UV fold. Like here, I have lifted the bladder here. And once you lift the bladder, you immediately get the plane. And always go maximum sharp dissection. Whenever you are doing central dissection, go for maximum sharp dissection. Now only these two strands are left. When this is done, again the bladder is clear and it's done. So this is another method. So for previous 3 LSCs, 2 methods are good: lateral window technique and central dissection. Whatever suits you, whatever you find comfortable at that moment, you should be able to do. This is done. And the last case is a ventrofixed uterus. I'll just show. This is done. This is the picture sometimes we get on surprise, where the uterus is stuck to the intra-abdominal wall. This can even happen in previous single section if it was not done properly or if there were adhesions. So you should not get scared when you get such a picture. Actually, the paravesical spaces we can easily create. Only thing we have to remember is we should not divide the round ligament. Go anterior to the round ligament and give a horizontal incision on the peritoneum. And we enter the paravesical space on one side. And same step we have to repeat on the other side also. And since uterus is already under traction, the space opens up very easily. And just because the uterus looks like this doesn't mean that the bladder is densely adherent. As you can see, I have easily found the plane here. And now I'll repeat the same step on the other side once this is done. Always keep the uterine artery as your marker and stay anterior to the uterine artery. Now this is the other side. See, I'm holding the round ligament with my Babcock forceps, and I'm giving a horizontal incision anterior to it. Don't cut the round ligament. And now I have reached the paravesical space on that side. And this is just skeletonizing of the uterine artery on one side, and just cauterizing the uterine artery so that bleeding is not much. And as you can see, I have already reached the bladder here also. Now only thing left over is the broad adhesion band that I have to incise. So here also bladder is dissected, and what we have to do is right now just divide the band. When we are confident that the bladder is down, this is only an adhesion band. Even if it looks scary, it is nothing but adhesion between the uterine tissue and the peritoneum. I've used vasopressin in this case because I was scared that I might cause, I was also expecting a lot of adhesions, but most of the cases, the adhesions are not much in such cases. So these are the videos which I had to show. Different methods of bladder dissection. Thank you. This is done. Thank you. Any questions? Any doubts?
Thank you, Amit. That was interesting. And now a few more students from Sumandip Hospital. They are going to present a what is it? The poster, or yeah, poster on ruptured uterus. And I would like to ask Vipul sir to just do the judging. Vipul sir, 3 posters છે તમે ખાલી judge કરવાનું છે. So he's Dr. Savan Shah and he's going to present on ruptured uterus.
Hello. Good afternoon, everyone. Myself, Dr. Savan Shah. I'm a second-year resident in obstetric and gynecology at Sumandeep Vidyapith, deemed to be university and medical institute and research center. I am presenting the case of ruptured uterus, guided by Dr. Piyusha Chandrayan, ma'am, associate professor in obstetric gynecology, and also my guide for thesis, Dr. Deepa Kilar, ma'am, associate professor in obstetric gynecology in the same institute. So here I am presenting the case of ruptured uterus. Firstly I will define what is ruptured. So it is a complete division of all 3 layers of the uterus, of the endometrium, myometrium, and the perimetrium. So clinician must remain vigilant for the signs and symptoms of uterine rupture. So uterine rupture can cause serious morbidity and mortality for both the women and the neonate. Term replies that gravid uterus is involved, though ruptures have been noted in the non-pregnant uterus also. So uterine rupture can allow a part of the fetus or amniotic fluid or the umbilical cord to enter the peritoneal cavity or broad ligament. Uterine rupture can cause abdominal pain, vaginal bleeding, a change in the contraction pattern, and non-reassuring fetal heart rate racing. So in my case, there was a lady of 21-year-old female, gravidato paravan live 0. She has a previous preterm vaginal delivery. The baby got dead within 2 months after, and now she had a history of prolonged labor, for which a failed attempt was done at query forceps delivery at somewhat PHC at Peripheral Health Center. And after failed attempts, a patient was referred with episiotomy suture to CSC Jabuka, and from there the patient came to Dheeraj Hospital, that is the SOU with Sumandeep Vidyapith. From that CSC Jabuka, patient further referred to Dheeraj Hospital with sudden onset abdominal pain, and it was in referring note that it was mentioned with ruptured uterus and intrauterine fetal death of the baby. On examination, patient was conscious, oriented with time, place, and person, surprisingly. And vitals were the pulse were 132, BP 100 by 60 millimeter of mercury, and in per abdomen, uterine contour was not felt clearly, and FHS was not localized by stethoscope and Doppler, and fetal part felt superficially up to Zifi sternum, and by per abdomen it was suspected to be an intra-abdominal fetus. By local examination, patient was, we suspected that patient underwent by fundal pressure they tried to deliver at PHC. So we suspected repeated episiotomy sutures present and slight oozing from episiotomy site. The baby was still inside the IUFD, and in per cervix was high up, episiotomy stage is present. Provisional diagnosis. Provisional diagnosis was gravidato paravan live 0 with 40-week 2-day with ruptured uterus with intrauterine fetal death. In investigation, we did a trans-abdominal USG. The findings were the FHS and movements were absent. The fetus was lying in abdominal cavity with free fluid present, and a defect like we call a rent or rupture or about 1.5 centimeter in the anterior wall of the uterine segment, lower uterine segment, with evidence of fetus and placental expulsion into intra-abdominal cavity. And the impression the regulations gave was IUFD with uterine rupture. In lab investigation, surprisingly, the CBC profile was normalized because 13.1, WBC 13,000, and platelets 1.94 lakhs, and RFT left in correlation probability in normal range. And we made a confirmatory diagnosis of like anterior or lower segment rupture of uterus. That was actually an intraoperative finding with IUFD. So after explaining, the patient was shifted to OT and blood products were arranged, and intraoperatively we carried a exploratory laparotomy and under spinal anesthesia on October So a transverse rupture was found along the length of lower uterine segment present, and a hematoma of 6 by 6 centimeter in the left broad ligament, and bladder was found intact, and around 700 ml of blood was found in abdominal cavity. So there was a huge amount of hemoperitoneum that was drained, and after that the vent was present along, and we delivered the baby by phrase presentation, and which was IUFD. So it was delivered. I will show the video afterwards. The stillborn baby delivered by phrase weighing a 3.3 kg male, and also placenta were taken out, and the uterine margins were approx like in LSCS we do. And after that, vaginal expression was very much important because the episiotomy stitch was present. So we found cervical tear at 6 o'clock, and that was sutured with Vicryl, and episiotomy was further repaired, and patient had an uneventful post-operative period after that, and was discharged on day 8 in healthy condition. So as I discussed with my associate professor, that this kind of catastrophe can be avoidable with clinical assessment of labor and ruling out cephalopelvic disproportion. Probably this may be probably due to.
I mean, only 1 minute more.
Okay. Okay. This is probably due to unabnormal febrile pressure and oxytocin. So probably due to untrained staff. Okay. This is again numbers, and the conclusion was the uterine upgrade is preventable obstetric emergency associated with high fetal morbidity and mortality. The main cause were again grand multiplicity, obstructed labor, previous C-section, injudicious use of oxytocin and prostaglandins, injudicious use of misoprostol by coax, poor emergency transfer facilities and referral system. So the final message should be in case of prolonged labor, the patient should be immediately transferred to the tertiary care center where this kind of cases can be handled quickly. Thank you. Yeah.
Thank you. Next, Dr. Deep Patel, study and management of ruptured splenic artery aneurysm. From Sumandeep. Five minutes, it's.
नहीं टच यूट्रस एक पीछे इधर पीछे जाइए कहाँ सीधे सिक्स में पेस्ट किया किसने दिया आपने है आपको सेशन बोलता था सिक्स भी सबका है वो हाँ तो सिक्स भी होगा सिक्स पोस्टर प्रेजेंटेशन दिस इज द वन आडो में करो उसमें आडो वीडियो के पीडीएफ है आडो वीडियो रिकॉर्डिंग या लेकिन इसको फुल स्क्रीन या स्क्रॉल नीचे चले जाओ जूम का कहाँ से प्लस 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 कंट्रोल प्लस ओके हैंड ओके बस
Yeah. Good afternoon, everyone. Is it working? I am Dr. Deep Patel, first year surgery resident from Sumandeep Hospital. And today I am presenting a case, an interesting case, the first case I saw of exploratory laparotomy. It's a case of a ruptured splenic artery aneurysm. These splenic artery aneurysms, they are the third most common aneurysms occurring in our body after aortic, thoracic and abdominal aortic aneurysms. So it's a very challenging diagnosis to make, mainly because when patient comes to us they come to visit us with absolutely no complaints at times, unless and until it is converting into a rupture. Then the patient may present with abdominal pain and signs of hypovolemia. Other than that, the patient will have no symptoms at all. And so this fine evening in the casualty, after having a hectic day, when I was just resting my eyes, this patient comes to the casualty department to visit us. And I did my basic examination and everything. And he just had the complaint of abdominal pain since 6 months, which increased in severity since that afternoon. And he also had complaint of episodes of vomiting and nausea since 3 to 4 days. Other than that, he was vitally stable. I ordered blood investigations and USG. So blood investigations were unremarkable. There was nothing wrong in that. And the USG showed only splenomegaly and mild fluid collection in the upper pole of the left kidney. That is it. And then we ordered CECT abdopelvis, in which we found that there was the enlarged spleen with an outpouching measuring 1.5 by 1.4 by 2.3 centimeter arising from splenic artery in the center of hematoma. So what it actually was that it had already ruptured at that point, but somehow the hematoma plug was holding that bleeding back, and it was a ticking time bomb, we knew at that point. And we shifted the patient immediately in the operation theater and for the exploratory laparotomy, and patient underwent exploratory laparotomy and general anesthesia. And we ligated and we did the aneurysmectomy with the help of a CTVS surgeon, our beloved Manvinder sir there. And then we found the spleen to be infected as well. So we did the splenectomy as well at that point. And after that, patient was absolutely fine and the outcome was really good. We discharged the patient on POD 14. And till that patient, on every alternate day, he still calls me to thank me, even when I did absolutely nothing other than assisting. So, yeah. And the thing with as I said, aneurysms, that they come to us with absolutely no complaints. So it is really difficult as surgeons for us to diagnose that whether this patient, what is going on, right? So these okay. So my conclusion is that we should consider the possibility of aneurysms in the patient that come to us with the complaint of abdominal pain and signs of hypovolemia, because prompt treatment is detrimental to the patient survival. Thank you.
Thank you. Next, Dr. Sanchit Sangai, Study and Management of Traumatic Diaphragmatic Hernia.
Good evening, everyone. Myself, Dr. Sanchit Sangai. I am a first-year resident in SBKS Medical College, pursuing my general surgery. So the topic that I have selected for today is study and management of traumatic diaphragmatic hernia. We all know diaphragmatic hernia is of two types, congenital and acquired. The traumatic diaphragmatic hernia comes under the acquired category. So traumatic diaphragmatic hernia is one of the surgical emergencies which needs to be managed urgently and with utmost care. The patient presents with complaints of acute respiratory distress, warranting an emergency laparotomy involving the reduction of contents of the diaphragmatic hernia and its repair. So the case that I saw was the patient, a 48-year-old male who came in our casualty with complaints of acute respiratory distress and chest pain following an alleged history of fall from tree. This 48-year-old male had just one complaint of acute respiratory distress following chest injury. Now, the chest injury that can result in traumatic diaphragmatic hernia can be of two types. A shearing force when applied to chest, it causes break in diaphragm from where diaphragmatic hernia can occur, or a straight blow to the abdomen, which may cause increased abdominal pressure, which might lead to traumatic diaphragmatic hernia. So the patient had chest injury, and when the patient was examined in casualty, upon examination, his vitals were stable, though a little deranged. He had tachycardia, he had tachypnea. His SpO2 levels were 96% on 4 liters of oxygen. And on respiratory examination, we found that on percussion, tympanic note was heard all over the left side of chest. We found that the breath sounds were heard only on the right side and they were absent on the left side. And heart sounds were heard on the midline and towards a little left. So we immediately took the patient for chest X-ray, and on chest X-ray, these were the findings. On the left side, we can see the bowel contents have herniated upwards, and we can see air levels there on the left side of the chest. So a CT was ordered for the patient, and on CT and USG, it became abundantly clear that the patient had traumatic diaphragmatic hernia on the left side. The patient's left lobe of the lung was collapsed, and the bowel loops were occupying entire side of the left hemithorax. So there was nothing more to be done now. The patient was urgently taken to the OT. The patient was prepared for emergency upper midline laparotomy. When the patient was opened and laparotomy was done, it was found that transverse colon, small bowel and spleen were herniating via the left lobe of diaphragm that was ruptured, and they were seen in the chest thoracic cavity. Then soon we reduced the herniated contents, we fixed the bowel, we reduced spleen, and we fixed and repaired the diaphragmatic ruptured part via a mesh. And after this reduction was done, defect was closed with Prolene suture, and mesh was used for the reinforcement of this defect. And finally, an abdominal drain was kept in abdomen, and all the sutures were taken for the closure. So the result was the patient had to undergo emergency laparotomy for traumatic diaphragmatic hernia repair. The patient's post-operative period was uneventful. He was kept in ICU for 2 days for monitoring, following which chest physiotherapy, mobilization, respiratory exercises and spirometry was done. And the patient improved rapidly, and he was discharged on 10th post-operative day. The patient's post-op condition is still stable, and the post-op follow-up is uneventful. So the conclusion is that traumatic diaphragmatic hernias, though rare, are potential surgical emergencies, but they can be handled nicely, and they can be treated correctly if they are managed with immediate diagnosis and prompt treatment, because surgical intervention, if done early, has great prognosis. Thank you.
Thank you. Next, Dr. Kalpan Patel, study and management of case of stone formation in post-cholecystectomy stump.
Good afternoon, everyone. I am Dr. Kalpan Patel from SBKS Medical Institute and Research Center, first year general surgery resident. Today I am going to present you the case of study and management of rare case of residual cystic duct stump stone in post-cholecystectomy stump. Clinical manifestations of choledocholitis include obstructive jaundice, pancreatitis, and acute cholangitis, which include some symptoms of acute abdominal pain, postprandial fullness, nausea, vomiting. Clinical studies have been shown that the presentation of these symptoms, especially within 3 years of cholecystectomy, are most common reason for the residual or the recurrent stone formation, which is predominantly in cystic duct. A patient was a 33-year-old female, which present in the OPD with chief complaint of abdominal pain, particularly in right epigastrium, right hypochondrium and epigastric regions, and also with the nausea and vomiting since 7 days. Patient had a surgical past history of cholecystectomy,
and post-cholecystectomy stent removal. Patient USG was done, which showed 11.6 mm calculus in cystic duct and a 13 mm calculus in terminal CBD. ERCP was done, which was suggestive of dilated CBD and a single filling defect in the lower CBD. Sphincterotomy was done, and on balloon sweep, a single triangular stone came out and a free bile flow was attained. Due to repeated complaint of such similar symptoms, MRCP was done, which showed a stone in the cystic duct. Following that, repeat lab cholecystectomy was done. The cystic stump is a potential site for the stone formation, especially within the 3 years of cholecystectomy. Remnant cystic duct lithiasis has been cited as a cause for this repeated complaint of the similar symptoms which occurs to the patient. Another one association factors which have came out is of prior sphincterotomy and periampullary diverticulum formation, especially in choledocholithiasis patients. So patient underwent repeat lab cholecystectomy under GA, and patient was discharged on post of day 5th, and the post of duration was uneventful. So the conclusion is cystic duct stones after GB removal is not uncommon. Removal of the cystic duct stump via open or a lap method is the ultimate treatment, and a vigilant preoperative and intraoperative evaluation is the key for the prevention of occurrence of such patients. Thank you.
Thank you. Next, Dr. Jainam Shah, study and management of rare cases of mammary tuberculosis.
Good afternoon, sir. I'm going to present a topic of study and management of rare case of mammary tuberculosis. Mammary tuberculosis is a very rare manifestation of extrapulmonary tuberculosis, which is more common in high incidence regions like India and Africa. It is common in reproductive age group and in multiparous women, especially in the lactating period. And the common presentation is a lump in breast. In our case, a 41-year-old female presented with lump in left breast since 3 months, which was rapidly increasing in size, and she had prickling type of pain since 10 days. On examination, we found that the lump is of 5 into 3 centimeter size in the upper outer quadrant, which was the lump was mobile and it was not fixed to the chest wall, and the nipple retraction was present. So we ordered a USG scan, and in that we found a hypoechoic collection of 5.4 into 2.8 centimeter in the left upper outer quadrant with internal echoes present and internal vascularity present as well. So we did a lumpectomy and sent the lump for HPE, and in the HPE report we found that it had granulomatous inflammation of breast with the abscess formation, most probably of tubercular origin because of the caseating necrosis found in the lump. The post-op period was uneventful, and so we can see that tubercular mastitis is generally unilateral and seldomly present in males, generally more common in females, and it's more common in immunodeficiency states like HIV. The route of spread for tuberculosis is hematogenic or lymphatic. Sometimes it's direct as well, but it's less common. If there are recurrent fistulas and abscesses which are not resolving on antibiotic therapy, then it should raise suspicion of tubercular mastitis. Gold standard investigation for this is Zn staining, culture, and PCR. The treatment includes anti-tubercular therapy and surgical excision only. In conclusion, we can say that tuberculosis of breast is uncommon even in countries where incidence of tuberculosis is high, and it can present a diagnostic problem on radiological and microbiological investigations, and thus a high degree of suspicion is needed. Thank you.
Thank you. Thank you, sir. Thank you, Vipul Kapadia, sir, for judging. The results will be announced at the end. Thank you from the Sumandi. The next section is selecting the best embryos by Dr. Sudesh Kamath, sir. Sir, please, sir.
Dr. Sudesh Kamath is the Laboratory Director, Bloom IVF Group, Mumbai. He is the past Chairman of Embryology ISAR 2018-20. And he is a Member Secretary, Ethics Committee, Babies and IVF ICSI Center. Over to you, sir.
This one. I'd just like to thank Dr. Kishore Nadkarni, sir, Akshay, Dr. Pooja, Vaibhav, all of the members involved who are with 21st Century for inviting me here. It's great to be among dignitaries like Dr. Kapadia, sir. So I will talk about selecting the best embryos. I'll make it short because I think we are all getting very delayed. We had a beautiful debate, whether a single embryo transfer or you transfer 2 or more. So all of us agree we want to do a single embryo transfer. But how do you select which is the embryo you are going to transfer, which will give you the best, like one embryo will give you a live birth? That is where, we are all stuck. Even today, I don't think anyone can answer this question. Who can select the best embryo? We all see me, Dr. Prabhakar here. All of us see, okay, this is the embryo which looks good morphologically. But does it give us a pregnancy? It doesn't. That's why we put in 2 blasts, 3 blasts also sometimes, so that, we get a pregnancy in the first attempt. Normally, we have 2 different methods of selecting embryo. One is invasive, which I think only a very highly skilled people like Dr. Prabhakar and all who can do it. You do a biopsy, and then that, okay, this is the euploid embryo. So this is what I want to transfer. But still that doesn't, it can't guarantee you will get a pregnancy with that. But most of the centers, they prefer non-invasive method. Like how you all doctors say, do no harm to the patient. That way we have to select a embryo where there is no harm done to the embryo. Biopsy and all you do is good, you get euploid embryo, but it's very invasive, require very high level of skill. So in our normal thing, what we do, what we see is the morphology under the light microscope. So you just don't have to see the oocyte, the embryo, you have to see how it progresses. Once the oocyte, sperm enters inside the oocyte, there's a sequence of events which occur. Like fertilization, then there are embryos, 2 cell, 4 cell, 8 cell, entire sequence, that is very, very important. The timing of that sequence is very important. What we are doing when we are seeing blastocysts, in the end we have say among 10, we have got 5 or 6 blastocysts. Okay, look at the blastocyst, this is the one I'm going to select. But what is even more important is you have to follow the entire sequence. Like how are the oocytes initially? Were the oocytes good? Then you will get a good embryo. So you can see here, sometimes you get these kind of oocytes. And then what blastocysts do you expect to get? You may get, there are cases where you have got pregnancies also, but this is what you ideally want. So what I'm trying to say is the entire thing you should see, the oocyte, what is the quality of the oocyte, how are the embryos, when they are 4 cell, 8 cell, morulus, all that is important. Here you can see this is, day 0 is the day of pickup, day 1 is the oocyte, how it looks. It is fertilized, it becomes a zygote. At 36 hours, you will see it becomes 2-cellular. At 48 hours, you will see it become a 4-cell. This is the ideal thing what you want, different stages. Day by day, then it becomes a 8-cell. Then it progresses into an advanced cell, that is a morula. You will see it becomes compact. You won't see individual blastomeres. And this is then blastocyst, where there's proper differentiation. You get the trophectoderm cells, you get the inner cell mass, the size increases. And I think nowadays almost most of the centers, all of them have shifted to blastocyst culture. Earlier we couldn't do that because media was not available. We couldn't culture them beyond 8 cell. Anyone here nowadays, there are so many papers are coming where they prefer doing a day 6 transfer, when the blastocyst is either hatching out, or some of the reports are there where they have seen hatched blastocyst. That's also they have put in public such papers. This is another tabulated form of different embryo development. Like I said, very, very important. Say you have got 10 oocytes, you fertilize, you find 10 2PN, and then most of the times what we all do, we all stop checking for fertilization because we are doing ICSI. We know, okay, only one sperm has gone in, so it's going to fertilize, and many of them don't even see day 2, day 3. Directly they see day 3 or blastocyst. But very, very important is because say 2PN, either is no fertilization, you don't get 2PN. But there are sometimes, you get only a single pronuclei. Many times you should not confuse with that syngamy which occurs when both of them come together. Many times you have that I'll come further, 3PN also which occurs. Then every stage, suppose then you have gone beyond, you have seen at 4 cell stage, you are seeing around say 7, 8 embryos, you have become 4 cell. 1 or 2 you will find lagging behind, 2 cellers. These are the ones which are arrested. So every stage there is a block, at 4 cell block, 8 cell, you have to see that sequence. On day 3, if I say see maybe 6, 8 cellers, and I see 1 or 2, 4 cellers, I know those are arrested. So those you just eliminate. Like say even blastocyst, many times you will see out of 10 fertilized, 10 embryos, you may see only 5 or 6 blasts. Others all have got arrested. So this is nature's way, of eliminating. Most of these embryos which are arrested are supposed to be aneuploid. Embryo grading, this is what used to happen earlier. Now we are all doing blastocyst, but these are some of the methods, like pronuclear scoring system was there. Then we used to score on day 3, how are the embryos. This was very popular, Z-score scoring system. You can see on top those precursor bodies, they are aligned at the junction. It was meant that these embryos, these zygote, they have the best chances of implantation. Then score B, where they are scattered. And you can see score 3, where they are either scattered on one side and aligned at one place, or they are uneven, the precursor bodies. And worst was score 4, where it said implantation was very, very low. You can see the pronuclear size, one is less, one is big, or they are not even joined together. So the thing was with this scoring system, the score 1 and score 2 had the best implantation. So these are the fertilized eggs, and then these were what were being transferred. These are proper, you can say zygote 2PN, and that is 3PN. You need to be very, very careful. Even when you're doing ICSI, very important to check fertilization. Sometimes what happens, the polar body doesn't exude, comes out in the form of a 3 pronuclear. So that is abnormal. And what happens, suppose you miss out this fertilization. Next day you will see it doesn't become a 2 cell, it becomes a 3 cell. And on day 3 you will see it becomes a 6 celler. And many studies show that embryos which are growing fast, those are the best ones. And it may be you are selecting the 6 celler ones, other are 4 cell, but you are selecting the one with 3 pronuclei. And basically that won't grow further, or it's like completely aneuploid. So very important is to check fertilization. This I just mentioned your scoring system, even cleavage we used to see like earlier, the blastomeres and all we used to see. This was the classification, number of blastomeres, the cell number, where they are 4 cell, then regularity, whether one is large, one is small, and very important was degree of fragmentation. Earlier we used to classify them, grade them 1, 2, 3, 4. Some used to classify grade 4, grade 3, grade 2, grade 1. But now it is almost like good, fair, and poor. This is the grading. But now all this is because of blastocyst culture and transfer. This all is not being followed now. Fragmentation is very, very important, because if you get fragmentation, they are all blebs, from cytoplasm which comes out. And then I'll show you the pictures. That will compete with the embryo. The growth and everything is compromised. So these up to 10% of fragmentation is okay, but if there is higher fragmentation, implantation rates are very, very low. And if you are getting fragmentation, then you have to actually worry about your, maybe oocyte in some cases, but your culture conditions, your media, incubator, is there something wrong? That is when you get high level of fragmentation. This is which I think many people, many of the embryos will always miss out, multinucleation. You'll find multiple nuclei inside one blastomere. And this you can see very clearly at when the cells are two cell, become this thing, 2-cellular or 4-cell. Otherwise, as it goes beyond, you will miss it, you can't see it. And these embryos will have very high chances of being aneuploid. Like you can see here, up I have kept all the good embryos. These are all pictures, taken from here, but actually when you're doing it, you don't find such embryos, good embryos without fragmentation. Here you can see uneven cleavage. The one with multinuclei, you can see in the top blastome here, you can see 2 or 3 multinuclei, the nucleus inside. So this is 100% aneuploid. If you don't check these embryos at 4-cellular, which most of them have stopped checking now, you will end up this will all become a good blastocyst. You may end up transferring this. And again, then there is implantation problem. And that's the case with high fragmentation. Of course, that you can spot it easily. And normally these don't progress forward. Then you get so many cytoplasmic anomalies inside the oocyte. Sometimes you get granularity. Like I showed you the first picture, oocyte, good and bad. You get cytoplasmic pitting, small pits you see inside. Although some reports have shown that this is, better, higher implantation, but we have not been able to find good blastocysts or pregnancy rates with cytoplasmic pitting. Vacuoles also, up to 1 or 2 vacuoles, it is supposed to be okay. And when this progresses further, it becomes a blast, all this disappear. You won't see vacuoles inside, you look like a good blast. But when you're selecting the blastocyst, that is the time when all these things are important. So when you're culture all your oocytes, when you're injecting the embryos separately, note them down. So you see what are the oocyte characteristics, how are they, were they vacuoles inside. So if you're getting 2 good blasts, but one had a vacuole, so I would prefer not to transfer this, of course, but then I'll always freeze it, and I'll transfer the other one where there were no abnormalities. This was earlier, now nobody is following this graduated embryo score. Compaction also, this is an advanced stage. Here also what is important is the entire embryo has to be compacted. You can see here, each and every cell of the blastome, 8-cell, 12-cell becomes one huge mass. There are sometimes, you get some only blastomeres will become compact and some cells are outside. Those again have a poor implantation potential. I'll just tell you something, when I was maybe 20 years back, we used to culture only up to day 2, day 3. There was no media where we would culture further. So we had one case, I had got 3 excellent 8-cell embryos. And somehow the patient couldn't make it and it got delayed. Next day we went for the transfer, next day evening. So in the morning I came and checked. I saw all 3 embryos, 8-cellular. There was nothing. They all looking just like oocytes. I was so scared. This is the first time we used to make our own media. Then luckily we had a library. I rushed down and then I think Dr. Bongso's blastocyst culture read. And then I realized, with media, I don't know what error I made in the media. I got morulas there. This was 20 years back. So these are very advanced cells. Blastocysts, you get 2 different types. These are very advanced. The trophectoderm you have, which forms the placenta, your inner cell mass. This is just a picture of this. This is very important, grading system you see. This was in 2000, Gardner, when he had made his sequential media and all. At the time he showed, when you transfer 2 top grade A, where it was like more than 3 AA, there was an implantation of 72.8%, pregnancy rates were 86.8. When you do a single top grade embryo transfer, it had come down significantly. And lower than it is just 28% is the implantation rate. So this showed, the effect, blastocyst is really helpful, the culture. But see, you are putting 2, one of them you are implanted, but because of that, you are getting much higher clinical pregnancy rates. Nowadays, you have got different grading system for blastocysts. I won't get into all that. These are the early blastocysts, and these are the late ones, The lower ones are the ones which are hatching, that is completely hatched. Nowadays reports are showing that also does help, but it is not easy to load all this. It is very, very sticky also. So most of us are doing all this routine morphological assessment. But there are limitations to that routine morphological assessment. And there was a very big, nice article, 2020, where they have shown, finally, whether we are doing day 4 or day 3, day 4 blastocyst culture, the pregnancy clinical or take-home baby rate is just around 30%. What was earlier also when we were transferring, say, 4 or 6, 4 embryos, day 3, or we are transferring 2 blasts, still the pregnancy rate still remains, take-home baby rate is even lower, 25, 26%. So what can you do further? Nothing more you can do. Which are the blasts you have got? 3, 4 blasts. Which are the ones you are going to select? Morphologically, everything looks good. So beyond that, we can't do anything. So that is when I think Dr. Munjal had a talk about artificial intelligence. So all that is going to come into play now. This is what we have. This is the latest we have got. And this is, we had the earlier one also, but this is even further advanced. It will, measure everything, right from the time the oocyte is placed, all the events, complete history of that, and then it gives you a score. They call it the IDA score. So this is what we are now using, because we are also shifted more to single embryo transfer. So this, and then we use our judgment, and we are able to select the best embryo on this. And success rate is slight, it has improved a lot. Of course, there are many debates whether this is really helpful. Some of the things, you can see conventional screening and time lapse, multinucleation, fragmentation, all these will be detected by this time lapse. And they will tell you, according you get the score. Even the reverse cleavage, or even from one this thing, 2 cells of 2 cell becomes a 3 cell. All these, when you're seeing, you can do it all manually, but a lot of exposure to the oocytes, to the embryo. So all this will be done by the time lapse. So finally now, embryo selection. We have selected, okay, this is the best embryo. And all this we can do blastosis and all because of embryo vitrification program. We had a beautiful talk by Dr. Pooja, who is for freeze-all. That has actually improved the results a lot. We are also now, majority of our cases, we are doing freeze-all. Then once the patient is properly, properly, we have everything, receptivity, everything, then only we transfer, and success rate has increased. So you need an embryo vitrification program, good blast, good uterine receptivity. But finally, even after all this, if your embryo transfer technique is not good, there is no success at all. So all these three are equally important. So blastocyst transfer, freeze-all, that is what you get the best results. With this, I would like to conclude my presentation. Thank you, everyone, for your patient hearing.
Thank you, Sudesh sir. Now, I would request Dr. Sujay to please present a memento to Dr. Sudesh. Thank you so much. Thank you, sir. And now we are going to our next talk by Dr. Vipul Kapadia, sir. And he's going to talk on ovarian hyperstimulation, prevention and management.
Good afternoon, everyone. I think whole morning was spent on looking at embryos, how the embryos are, how the embryos would stick to the uterus, will give pregnancy. But I think we've ignored the patient completely so far. And that's a fairly risky thing. We just cannot afford to ignore the patient herself. The patient who has come to you with lots of hopes, and she wants to go back, hale and hearty, of course with a baby. But even without a baby, she should be hale and hearty. So I thought of talking to you all on a very dreaded problem, and that problem is of ovarian hyperstimulation syndrome, and I want to discuss things on prevention and management of OHSS. OHSS is the most serious, potentially fatal, and iatrogenic complication of assisted reproduction technology. And it is characterized by a broad spectrum symptoms and signs of abdominal distension, pain, discomfort, enlarged ovaries, ascites. And all this is because of enhanced vascular permeability, shift of the serum from intravascular space to extravascular space. What really happens is that we manage in ART to develop a large cohort of follicles, and we give HCG trigger, and that produces massive luteinization of all the follicles. And the granular cells of these luteinized follicles, will produce a lot of vasoendothelial growth factor and other angiogenic substances, and that leads to leaking vessels, highly permeable vessels, and that leads to fluid shift from the vessels into the third space, and that leads to edema, ascites, hypovolemia, hydrothorax, etc., etc. There are two types of OHSS. The early onset, and that is in the first week or 8 days of your ovulation trigger. And the second OHSS is 9 days after the HCG trigger, and that is usually endogenous HCG, that is pregnancy-induced OHSS. So how do we prevent this dreaded thing? We have various measures, and we'll tackle them one by one. The first is predicting hyperresponders, predicting women who will develop OHSS. And there was a beautiful study by this man called Aflatunian. You like that name, Aflatunian? It's a superb name. And he said that young age, long menstrual cycles, PCOS, especially thin PCOS, and hyper response at the previous cycle are suggestive of high ovarian response. Stronger predictors than these are AMH and AFC. That is, AMH levels more than 3.5 and AFC more than 16 antral follicles have shown to be the most appropriate cutoff for hyperresponse. So, if you have a patient who on day 1 shows an antral follicular count of more than 16, and if a patient has day 3 AMH, we usually do it at any time, but quite often we do it on day 3 because FSH, LH, AMH all go hand in hand, and if AMH is more than 3.5, you have to be on guard that this woman is likely to have hyperresponse. Gone are the days when we have a fixed protocol. Now we all practice individualized stimulation program. Initially, we used to have age, BMI, previous ovarian response to gonadotropins, and day 3 FSH as the main parameters to judge or to determine the dose of gonadotropins. But now, for last decade or so, we have been moving towards more and more in incorporating AMH values and day 1 AFC values. With continuous monitoring with transvaginal sonography and serum E2 levels, we try to find out if the woman is really responding as we want her to respond. But if she is responding more than what we expect her to respond, we decrease the dose of FSH by 37.5 international units. If we find that the woman is not responding enough, we increase by 37.5 international units. And so we achieve an adequate oocyte yield of about 8 to 15 per cycle. Remember that the type of gonadotropin preparation, urinary or recombinant, FSH or HMG, does not appear to affect the OHSS risk. Now, how do you monitor? Let's go back to the Cochrane analysis. Bhattacharya and others analyzed this and published in Cochrane analysis, and they said that for an ordinary patient who is not likely to have OHSS, only transvaginal ultrasound monitoring is sufficient. But in the same article, they conclude that combined monitoring needs to be done as a good clinical practice in a woman who is likely to have OHSS. And so they also concluded that before a trigger, if a woman has more than 20 follicles, now it is said to be more than 15, and if the E2 levels are more than 3,500, you have to be very, very careful that the woman is likely to have OHSS. Then we give drugs to prevent premature luteal surge. We can give either agonists or antagonists. Now, agonist stimulates both FSH and LH. And so you'll have greater follicular recruitment when you give agonists, because both FSH and LH are stimulated by agonists. And in this, HCG or LH trigger is a must. And so the woman on a GnRH agonist luteal phase suppressant will have a greater chance of developing OHSS. When you use GnRH antagonist, you have to give GnRH agonist as a trigger. Lesser chances of OHSS, but unfortunately the implantation rate also may decrease. So if you have on the day of trigger a situation wherein the E2 is more than 3,500, and if the follicles are more than 16, what do? We do a procedure called coasting. What is coasting? You stop gonadotropins, but you continue with agonists or antagonists. And you do daily transvaginal sonography and daily estrogen E2 estimations. By stopping gonadotropins, the larger follicles will keep on growing independently. But the smaller follicles, because there are no gonadotropin support, will become gradually atretic. And within 3 days, the E2 level will fall to less than 3,500, and then you can safely give a trigger and continue with your ovum pickup. But if the E2 level does not fall below 3,500, then you have to actively think in terms of cancelling cycle. Is it good? Cancelling cycle is a very traumatic thing. It has emotional and financial implications. It is frustrating, not just to the patient, but also to the doctor himself or herself. But now, fortunately, we have antagonists, and we don't usually practice cycle cancellation. But still, it may be valid if after day 3 of coasting, the estrogen value does not fall to less than 3,500. Metformin is a wonder drug. It decreases even the risk of OHSS, 95% confidence interval from 0.49 to 0.18, nearly 3 times less. And why does it act? It decreases the intra-ovarian androgens. It makes the follicles less sensitive to circulating gonadotropins. And smaller follicles, non-periovular follicles, are reduced. But you have to start not in that particular cycle. You have to start a month or nearly 6 weeks before you plan an ovulation induction. With metformin, there is really no difference in pregnancy rate or live birth rate. So now we have come to the stage of triggers. HCG 10,000 international unit is the drug of choice or routine drug for final oocyte maturation. But remember that HCG has increased bioactivity as compared to endogenous HCG, endogenous LH. It has a longer half-life, nearly 24 to 36 hours or more. And it is 6 to 7 times more potent than endogenous LH. So in these conditions, what do? You can decrease the dose of HCG. We have been decreasing the dose of HCG to 7,500 to even 5,000 units on the day of the trigger without any ominous results. People say that you can decrease the dose to even 2,500 to even 3,000 for good oocyte maturation to M2. High HCG, remember that routine urinary HCG or recombinant HCG, you get the same results. Don't go by the pharma company's push that recombinant HCG is better than urinary HCG for preventing OHSS. The most important thing is recombinant ALH, L-Hardy, is much better. It has half-life of approximately 10 hours only. It may be better, but it is really not proven by scientific studies. GnRH antagonist trigger induces FSH and LH surge, and it triggers natural oocyte maturation. It is useful in patients with high risk for OHSS, both early and late. It is useful and beneficial mostly in oocyte donors. And there's a new drug in the market, that is kisspeptin. Antagonists act on pituitary. Kisspeptin acts on hypothalamus. It induces GnRH releasing hormone, gonadotropin releasing hormone from the hypothalamus, and so only the reserve LH will be exposed to the oocytes. But it is still experimental and of course not yet available in India. And the game changer is of course embryo cryopreservation. It prevents late onset OHSS for sure. You are not putting an embryo, the woman does not have any endogenous HCG, and she will not have late OHSS. And we practice embryo cryopreservation for both a woman who has had HCG trigger and a woman who has had even agonist trigger. In olden days, a few, maybe 5-7 years ago, we used to quite often give human albumin to women who has been, who was exposed, who is likely to have OHSS. It increases the plasma oncotic pressure. It binds to the protein and inactivates the vasoendothelial growth factor. But the benefit is borderline. 95% confidence interval, 0.99 to 0.45. And recently, it is said that it may decrease even the pregnancy rate. Hydroxymethyl starch may reduce OHSS, but it is found to be quite toxic. Dopamine agonists. We've been routinely doing this. Cabergoline or quinagoline, both are useful. Quinagoline is nearly 3 times more potent to cabergoline for prevention of OHSS. Both inhibit VEGF phosphorylation and so decrease the vascular risk. Cabergoline is known to decrease OHSS risk in moderate and mild OHSS, whereas quinagoline is a drug reserved for moderate to severe OHSS risk. If a woman has had a bad OHSS, the next thing you may offer to her is an IVM, which is not really practiced very commonly. It requires minimal stimulation. Oocytes are aspirated at GV stage and then matured in vitro to M2 stage. It is experimental. OHSS rates are low, but even the live birth rates are quite low. The next thing is the natural cycle IVF or a minimal cycle stimulation. You give clomiphene citrate or letrozole stimulation and start monitoring from day 5 onwards, and start antagonists and gonadotropins from day 7, trigger, aspirate, ICSI and freeze all and transfer none. That will be the best. Coming down to management. The principles of management is essentially conservative. You have to identify signs and symptoms early and monitor. Very careful watch. Severe or critical cases only may be hospitalized. The mild cases will have only abdominal distension and discomfort. They may have mild nausea and vomiting, diarrhea. On ultrasound, they have enlarged ovaries. So what do you tell them? You ask them to take enough rest, take paracetamol, and instruct the patient to call you again if the symptoms worsen. If the symptoms worsen, and if you find that on repeat sonography the ovaries are enlarged, and if there is ascites, you have to do certain tests. And the basic test is hematocrit. If the hematocrit is more than 41, if the WBC count is more than 15,000, and if the proteins are less, you consider that she has moderate OHSS. And what do you do to that? In such conditions, you allow them to ambulate, but avoid physical activity and sexual relations for fear of torsion and rupture of ovaries. But it sometimes may be necessary. You have to, of course, do blood counts and transvaginal sonography every other day, or maybe in severe cases almost daily. And you may have to do abdominal tapping. Please avoid doing abdominal tapping per abdomen, because we as IVF specialists are more used to transvaginal tapping. So chondrosynthesis will be much, much better and safer for us, and it is guided. For pain relief, give paracetamol, but avoid NSAIDs. Oral opiates may sometimes be necessary. If with all this also the woman has tense ascites, severe pain, severe nausea and vomiting, weight gain more than a kilo a day, if she has dyspnea, if she has oliguria, if she has low CVP, syncope, venous thrombosis, then of course you have to do all the tests all over again. Also you have to do liver function tests in these patients. And then you have to give supportive care, IV hydration, chondrosynthesis we have already discussed. You have to anticoagulate all of these people. Pain management again with acetaminophen and opiates. Antiemetics and management of other complications like tapping of the pleural effusion, etc., with the help of your friends of other disciplines. If the woman is not pregnant, then within 10 days to 14 days, the symptoms will subside and the patient can be discharged. And so you consider that as OHSS resolution. The HCT will start becoming normal, ascites will become less and less. If the woman is not pregnant, as I said, it's within 2 weeks that she'll be all right. But if the woman is pregnant, it may take a little longer, maybe 2 weeks more. What about prognosis of women who has OSHS? They have a higher miscarriage rate. They have increased diabetes during pregnancy, increased hypertension during pregnancy. But other fetal or maternal complications other than this are not presently seen in second trimester. So we have discussed a very potentially fatal complication of ovulation induction, particularly for ART, and we have discussed the management in general. I hope that really encompasses almost everything. I thank you all very much for your patient hearing.
Thank you, Vipul sir. That was a very important topic which you covered such such vividly. Thank you so much. And I request Dr. Soumya Nadkarni to please present a memento to Dr. Vipul Kapadia, sir. We lovingly call him Vipul uncle because these kids knew him since childhood. And
Thank you, Soumya.
they are like family. Thank you, uncle. Thank you so much.
मैं आपको दूं? Thank you.
Thank you. And now we go on to our next topic, that is optimizing IUI results, which will be taken by Dr. Vaibhav Kapadia. Over to you, Dr. Vaibhav.
You have the connector, no? iPad का? हाँ, type से इधर. So, first of all, let me thank the entire Dr. Nadkarni family for having our entire family here. There's been a really long association between us, and I thank you all for being here. At the fag end of the conference, few people left tired faces, but I think there's a topic where we cannot afford to miss, in the sense, even if we do practice a lot of IVF, there will be times where we do a lot of IUIs. And we know IUI has gone into disrepute because the pregnancy rates with IUI aren't great. So what can we do to improve the success at IUI? The first documented application of artificial insemination was way back in the 1770s, where John Hunter used semen of hypospadias man and used it to inseminate his wife. Even James Marion Sims reported doing his first postcoital test and IUIs, and he did that in the early 1800s, but he thought ovulation happened during menstruation, so he wasn't very successful either. It wasn't until the Russians in the late 1800s and early 90s that developed the techniques of IUI as we know them today. So what is the basis of IUI? It's based on the hypothesis that you place a large number of sperms high in the reproductive tract, and that will enhance the likelihood of conception. So what is the basic requirements? You require ovulation, you require patency of at least one tube, you need to inseminate with decent number of sperms, and you don't have to have any pelvic infections. So it's used in mild mate factors, cervical factors, severe sexual dysfunction, or discordant couples. But it's basically used as an adjunctive procedure where instead of a timed intercourse, you're using IUI. But let's take a step back. Before we increase our successes as IUI, let's identify what will decrease our successes. So the diminished ovarian reserve. You know when a patient is more than 35, she's had previous cycles which haven't worked, she's had ovarian surgery, you expect that this from history that she's not going to do very well with these cycles. There'll be certain clinical markers like age, menstrual patterns, endocrine markers like AMH, ultrasound markers like low AFC. You'll tell us that this is not going to help us achieve a good result with IUI. Something that we've even borrowed from IVF, Bologna criteria, where we identify poor responders. Once you know that they're a poor responder, please don't try bothering with IUI. So you could do IUIs in natural cycles, or you could do with stimulation. With natural cycles, you have to document ovulation before you start doing IUIs. IUI is performed on the next day after you see it with an LH kit or document it using an ultrasound. And natural ovulation will give a better result in a natural cycle unless other than doing with HCG. But a lot of us don't do natural cycles IUI. I think it's a particular waste of time doing it. So we all do it with controlled hyperstimulation, especially in couples with unexplained infertility. And you'll use letrozole, clomiphene, gonadotropins, whatever. And we've noticed a higher pregnancy rates in stimulated cycles compared to natural cycles. However, there's still not a shade compared to the success we get with IVF. So when it comes to stimulation, the first thing that comes to mind is clomiphene. Unfortunately, that's not true anymore. It's been overtaken with letrozole, which is an aromatase inhibitor. It's a drug of choice now. You start with 2.5 milligrams a day, go up to 5 from day 3 to day 7 of cycles. But the thing to remember with letrozole is that when you use very high doses, it can cause endometrial thinning like clomiphene. Letrozole's had its bad effects. It had its bad repute. First it came, it was fantastic. Then it went into dispute. Now it's found its own balance in society, as you can call it. Clomiphene's still hanging there. We still use it often. Use 50 to 150 milligrams 5 days from day 3. And do not use HCG in these clomiphene-induced cycles. They do not do anything with the success rates. What will actually help is using gonadotropin. In older women, in younger women with diminished ovarian reserves, you start ovulation induction with gonadotropins on day 2, day 3, follow them on transvaginal ultrasounds, and when the follicle is more than 18, you can trigger them. But are they worth the cost? Using gonadotropins for IUI, when you have a limited success rate, you're pushing towards a cycle cost of almost as much as an IVF. So there were the trials conducted that instead, if you could remove the gonadotropin cycles from IUI and straight go to IVF, it might be cheaper for the couple. But what if we told you that you can do a gonadotropin cycle, still lower the cost, and still have an adequate success rate? How would that work? Of course, we'll jump for it. So instead of adding letrozole to gonadotropins, how about you adding letrozole to gonadotropins instead of adding gonadotropins to a letrozole cycle? It'll reduce the required dose of recombinant FSH. You'll get the same endometrial thickness and slightly better success rates compared to even a small gonadotropin cycle. It does not have any effect on cervical mucus. Although the pregnancy rates are better than using plain gonadotropins, it's not statistically significant. Can you replicate this with clomiphene? Unfortunately, no, because it causes endometrial thinning. That does not happen with letrozole. Antagonists are used now in IUI cycles as well, so to help uterine, endometrial, and ovarian synchrony to happen and prevent premature luteinization, avoid weekend IUIs. That's when we use antagonists the maximum. Once you've had your follicle growth, once you've had the endometrium thickened, then you can trigger it using HCG, that's 10,000 or 5,000 of highly purified HCG or 250 milligrams of rec HCG. You time IUIs 36 hours after the LH surge if you're doing a single IUI, or 18 and 36 hours if you're doing a double IUIs. There's no statistically significant which one is better, but if you're using it for male subfertility, use double IUIs. Recent reports suggest that if you're using urinary HCG, do an IUI 24 hours after trigger. If you're using recombinant HCGs, do IUI 36 to 42 hours. The number of IUI cycles max is between 3 and 6. Hardly you'll get any better rates after cycles 3. What is the way practically to increase your successes at IUI? When you handle semen, try and process it within 30 minutes. Try and do an IUI within 90 minutes of collection. Process it using swim up or density gradient, slightly better motile sperms after density gradient, but it's not significant. Do not do IUIs if the counts are less than 5 million because only IVF is really going to help them. What about using catheters? Flexible and rigid, both are same. There's no difference in success rates, but wash them with the medium. You'll increase your pregnancy rates by 50%. do your IUIs on full bladder. Full bladder straightens the uterus, easier IUI. Easier the IUI, increase in success rates. Lesser days of abstinence between the couple. 3 days or less gives us the best results. 10 days or more gives us horrible results, and you should ask them to have intercourse before. What about the actual procedure? These are very old videos, but bear with me. The IUI, try not holding the cervix, try and not have minimum manipulation, clean out the cervical mucus, and then using a flexible catheter if possible, and less number of, and slowly inject semen. Do it with ultrasound guidance. Avoid touching the tip to the fundus. If you touch the tip to the fundus, it could simulate uterine contractions, and that does reduce the rate. But does ultrasound guidance IUI actually help? Ultrasound guided IUI resulted in pregnancy rates of 23% compared to a blind IUI, which is significantly, statistically significant. A lot of us use adjuvants like metformin, inositol, scabigoline, estradiol, sildenafil, but I don't know whether they have any effect on live birth rates. Something that we've borrowed from IVF is PRP and GCSF. They're definitely known to increase endometrial thickness. What they do with the pregnancy rates, we'll have to wait and find out. But one thing we know that definitely helps and is almost doesn't take much of our time is endometrial scratching. It increases clinical pregnancy rate in unexplained infertility, even in mild male factors. And you'll see that pregnancy rates after endometrial scratching is 22% compared to 9% without scratching. You can use a Pipple cannula on day 8 or day 9 of the menstrual cycle to do endometrial scratching. Something that's newly come up is slow release IUI using an AV device or pump, where you put this catheter inside the uterus, and the machine is fixed onto the lady's thigh, and it slowly releases semen over 4 times, mimicking a more natural cycle. It's still experimental. It's not very practical in our day-to-day usage, where people are coming in, getting IUI done, and getting back to work. So time will tell whether that's useful or not. Luteal phase support is definitely helpful in increasing IUI success rates. You use dydrogesterone 10 milligrams 3 times a day, or you can use natural micronized progesterone. And if you're using GnRH analog as a trigger, you can supplement them with estradiol valerate as well. Post-procedure, ask them to rest for 15 minutes. You can ask them to resume their normal activities and not to worry about certain flow of fluid that comes out of their vagina. Sometimes you do expect complications like bleeding, infection, and multiple pregnancies with IUI. But there is a time when you to say no. No to IUI is when there are multiple IUI failures. There is very poor sperm morphology and count, and extremely low AMH and antral follicle count. I thank you all for a very patient hearing.
Thank you, Dr. Vaibhav, for the excellent IUI lecture. Fine. Vaibhav, you have got the memento? Yeah. Thank you so much. Now, Dr. Amit Varia is going to... Vaibhav, thank you so much for helping us out. And you are a savior. And Dr. Amit Varia is going to present an interesting video in the session of interesting videos, how I do it, master videos. So Dr. Amit, over to you. So the results of the poster presentation are there. Are the students of Sumandeep Hospital here? The students have gone. Chai pinenge? Okay, so if somebody could just call them, Vipul sir can give the...
Good evening, all. So, how do I do it? So, today I am going to present laparoscopic tubal recanalization. So, that is tubo-tubal anastomosis. I am demonstrating 2 cases out of my 27 case series of tubal recanalization, in which first case is with laparoscopic fallope ring and the second is with abdominal TL. So out of 27 cases, 21 cases were conceived intrauterine with 0% ectopic pregnancy rate over a period of 5 years, with the age ranging from 27 to 40 years. Out of 19 laparotomy cases, 14 conceived, and out of 8 laparoscopic cases, 7 conceived. That is 73.6% and 87.5%. So I have divided the surgery into simpler steps. Step 1, identify the TL site, mobilize it, excise the block segment, prepare the proximal stump, prepare the distal stump, mesosalpingeal approximation, and then tubo-tubal anastomosis with Vicryl plus 6-0. So this is the first case, which is of lap TL. Previous one LSCS and history of remarriage, hormones were normal. So this is the initial picture, that identify the TL site, then mobilize it. For that, you can use minimal cautery, but to prepare the proximal and distal stump, usually I use scissors. So this is the proximal stump, and you can see free flow of methylene blue. Now the distal stump was prepared, and that also checked for patency. Then we have to approximate the 2 ends to have a tension-free anastomosis. For that, we can use Vicryl plus 2-0. And the final step, which is most important, that is tubo-tubal anastomosis. Usually in laparoscopy, I use 6-0 Vicryl plus suture, and in laparotomy, 6-0 Prolene. As Prolene is difficult to handle laparoscopically. And so we have to take this 6 o'clock suture, then 3 o'clock, 9 o'clock, and 12 o'clock. So 4 sutures are suffice. If we feel that there are leaks and that is a major leak, then we can add additional sutures around the leak. Okay, and usually I do ipsilateral suturing, and I prefer to use only 2 ports, one primary and 2 secondary ports. So I have no opposite ports. So this is the final 12 o'clock suture for this right-sided fallopian tube. So there was a leak from that anastomosis. I have taken extra suture. So now this is the opposite fallopian tube. Similar steps, proximal and distal stump we have to prepare, and then this is the distal stump. Check for patency. Then mesosalpingeal approximation. And this is the tubo-tubal anastomosis. This is the final stitch. So now this is the final picture, bilateral free flow of methylene blue, which we can see. Second patient is of abdominal TL. So in that also, we have to prepare the proximal and distal stump. Usually we find more fibrosis, more adhesions in abdominal TLs. So in that also, the factors which affect the success rate are age. If age is less, then success rate are more. Then site of the TL, that ischemo-ischemic anastomosis has the most successful rates after surgeries, then ampulo-ampullary. And this method of TL, fallope ring has the best post-surgical results, then abdominal TL, and then electrocoagulation. The remaining tubal length is also important. If the tubal length remains after surgery around 5 to 10 centimeter, this gives best results. The duration between TL and recanalization surgery is also important. As duration increases, positive result decreases due to fibrosis. The hormone profile should be reasonably good. And the surgical skill, which is one of the most important factor for this success in this kind of case. Now this is the opposite fallopian tube. You can see the hydrosalpinx-like part of the tube in the middle segment. So all the microsurgical principles have to be followed. We should have good magnification, then only point hemostasis. Don't use unnecessary cautery. Gentle tissue handling with good tissue respect. Use irrigation whenever it is necessary, and fine suturing skills. Because without that, you cannot do tubercular anastomosis. Then what are the benefits of laparoscopy? Mostly, we all know that magnification is good, vision is good, then there are less chances of adhesion post-operatively, and the quick recovery time. That is the most important factors which favors laparoscopy if you are comfortable. So this is the end point of this case also. And this is the methylene blue dye which is freely flowing. So, and at the end, I would like to share one small success story of the laparoscopic recanalization. Volume.
Audio.
Audio.
नहीं working.
देख लो. ऑडियो चाहिए. एक मिनट में वापस वीडियो देख लेता हूँ, वही है ना वीडियो. So this is a case where I operated her in December 2021, and she came with in April 2022, within 4 months, that my period got irregular. And this is the surgery video. Then I will show the end result of that irregular periods. So she was worrying that before surgery I was having regular periods. After surgery, 2 months, my period was not coming regularly, and I have 1.5 month or 2 month amenorrhea. I don't know exactly the dates, and she was very much disturbed with the irregular cycles. So this is her result of bilateral tubal recanalization. And on TVS, I found intrauterine pregnancy with cardiac activity, without any medication, without any so the result of laparoscopic recanalization are so promising that we should give proper chances to this kind of patient. so they can have normal pregnancies. Thank you.
Dr. Amit Varia, Dr. Samya, can you please present memento to Dr. Amit Varia, sir? Dr. Gaurav, are you here? Dr. Gaurav? Yeah. So Dr. Gaurav Shashi, he belongs to Sterling Accurus Lab, Surat. Sorry, Dr. Gaurav Shastri. I'm so sorry. He's going to speak on decoding the genetic test from clinical perspectives point of view. I welcome you, Dr. Gaurav. So Dr. Gaurav is consultant geneticist with an experience of more than 14 years. He is the founder of Gene Care Genetic Diagnostic Lab Surat, which was established in 2011. And it's now a part of Sterling Accurus Diagnostics. And he's a geneticist basically, so he's going to throw us some light. And he's eminently qualified and experienced in cytogenetics, molecular genetics, genomics, and genetic counseling. So I welcome you, Dr. Gaurav, and over to you. The stage is yours.
Hello. Yeah. Thanks a lot, ma'am. Thanks a lot, 21st Century Hospital, for giving us an opportunity to be a part of this wonderful event. As we are late and having limited time, I will not speak more about. Like, we are here in a Millennium Update, to share updates in the field of IVF and gynecology. So it's opportunity for me to present an update of our own genome. It's our own database, I can say that, So, which are the tests available and which is the best test we have to choose to reach to our genome. So nowadays we say that there are plenty of platforms and tests are available, like from karyotyping to microarray to PCR to Sanger to NGS. Now which test to select and when to select? So like when we talk about pathology, we have defined so many criteria and we have formed so many pathological panels that for these patients or for before IVF or before going towards any procedure, we follow the protocols, but it is not possible in case of genetics, because it is for each and every patient you have to select a case-based test that is suitable for that patient clinical indication. So if I compare our genome with a book, the karyotype is the outer structure, or we can say it is the outer information that gives or that we gathered by seeing the karyotype. Microarray, we are coming across so many tests like microarray, micro. What is that? That deals with the deletion and duplication that let us know about the gain and loss of genome. So that is, when we start reading the book or when we start turning the pages, so these microarray is the pages of the genome. And when we exactly start reading the book by ATGC, that is what our sequencing is. So usually, in case of infertility, we have, two kinds of patients. They came to us. First is that they don't have any family history, they don't have any clinical history. Apart from that, they are having multiple missed abortion. In that case, what is the first test we can prefer or we can offer them? That I usually prefer karyotype, because it deals with the balance as well as unbalanced events that can detect by the karyotype. And in couples with no family or clinical history, I am much more interested, as they might be the carrier of any balance translocation or balance event which might cause imbalance event in the fetus. So majority of the time, they say that after sending 100 samples, 5 to 7 couples having an abnormal report. And even if we get an abnormal report, what is next? So I'll just say, If the couple karyotype is abnormal, what is next? We can offer them, this is the case of, a couple, male was having a translocation between chromosome 5 and 7. We offer them PGT-SR. There were 2 embryos were there. The second one you can see there was a loss in chromosome 5 and gain, the blue one, gain in chromosome 7. That indicates this is the abnormal embryo. The other one is the normal, and they can implant the normal embryo. Why karyotype is most important, I can say that along with microarray, many of the labs, they are offering microarray with Q of PCR, but I personally prefer microarray with karyotype because what karyotype can detect, microarray can't detect. What microarray can detect, karyotype cannot detect. So it is always to use a combination of karyotype and microarray. It is the case where, couple came to us after third missed abortion, where the second abortion they had a microarray report suggesting of trisomy 13. They again came for microarray, looking forward for the trisomy 13. I asked them to go for couple karyotype from the POC, and we can store the DNA. If everything is normal, then we'll plan for either microarray or sequencing based test. However, they denied that we are absolutely fine. We are not ready to give our blood for couple karyotype. You can do whatever you want to do from the POC. We performed the karyotype, and we found that there was something present on the chromosome arm 13p. So we reported at 13p plus, as the morphology was not good enough. Now we advise couple that you might be a carrier of any balanced translocation, and couple karyotype is essential. When we do perform the couple karyotype, the mother was having a balanced translocation between chromosome 13 and 22. So if we have done only microarray, definitely it would have suggest that this is the case of trisomy 22. But why it is trisomy 22? I mean, which is the cause leading to this trisomy 13 in the earlier case or trisomy 22 in this case? The answer was decoded by our karyotype that the female was a carrier of 1322 translocation or Robertsonian translocation. Now, why couple karyotype, not couple microarray? Majority of the labs, they are promoting couple microarray. They said that karyotype is dead end, and now the microarray which can take over the karyotype. But I remember this case. This was the case of Dr. Purnima ma'am. I still remember she was used to come to Surat every alternate day, thrice in a day. And she was not kind of a doctor that calls you regularly. But for this patient, ma'am called me that this is the patient, 4 missed abortion, 3 IVF cycle, patient was from Rajasthan, and they had their microarray normal report. So Gaurav, what we can now do? I asked ma'am, what about karyotype? Ma'am said, I have no idea karyotype, I'll just check it out and call you back. Then ma'am called me back and said, karyotype nahi hua hai. I said, ma'am, wahi karte hain. Ma'am said, microarray is normal, do you think this karyotype will help us? I said, ma'am, yes, let us just investigate. Once report come, then we'll discuss. From this patient, what we find, the female was a carrier of 15-15 translocation. Both the 15s were fused together. So in this case, in the ovum, there is a possibility that it would carry either both the 15s together and one ovum without 15. So there is no chance of viable pregnancy for this patient. I mean, we cannot offer PGD, PGT, because either there will be a trisomy 15 or monosomy 15. So that is why I always prefer not microarray in couple, but always prefer karyotype in couples. When we can use microarray, so this is the case, NT was very high, absence of radius in ultrasound, product of conception received, we offered karyotype and DNA storage. Karyotype was normal. Then we proceed microarray from the stored DNA. What we found that was a deletion in 1Q arm, and that caused a thrombocytopenia and absence radius. That was clinically matching with the fetus phenotype with the ultrasound findings. In the next pregnancy, we also check for couple karyotype, is there any balance event which is causing this deletion, or whether this deletion is pathogenic or not. We also cross-verified with couple microarray. Ultimately, in next pregnancy, microarray was normal and they delivered a healthy normal child. But not every time, these microarray deletions, whatever we report, we have to be very precise whether it is pathogenic or not. So this is the case where dual marker was very high, USG normal, amniocentesis was done, and microarray was done somewhere else. In microarray, they found there was a deletion in chromosome 18p. And on the basis of this deletion, there was no USG marker, nothing was there, fetus was absolutely normal, and they decided to terminate the pregnancy. They came to us for counseling. We counsel and we want to check whether this deletion was pathogenic or not, or whether it is present in either of the couple or not. So we performed both karyotype as well as microarray. Karyotype was absolutely normal. The female was normal for microarray, and in male we found the same deletion what was present in the fetus. That means that this deletion has no pathogenic role. I mean, on the basis of this deletion, they terminate the pregnancy, while USG and other markers were absolutely normal. So not every deletion is pathogenic. So nowadays, everyone is telling that microarray is very useful. Yes, absolutely, it is very useful. And we follow so many guidelines, and we say that ACOG says that CMA is the first tier test we have to perform prenatally. But, they have mentioned very clearly whenever there is a structural, one or more structural abnormality is there, then you prefer microarray over karyotype. They are not saying you replace microarray with karyotype. So this is the difference between a karyotype and a microarray. Karyotype can detect balance events, that is balance translocations, inversions, triploidy, tetraploidy, which microarray cannot detect. The advantage of microarray is that you not need to culture, you just extract the DNA and perform. But the advantage of CMA is that the smallest deletion and duplication which microarray cannot detect, you can pick up by using microarray. So I always say that use all the tests in combination, rather going with microarray with QF-PCR. I mean, QF-PCR or FISH will detect whether it is trisomy or monosomy or is there or not, but won't be able to pick up these balance events. So always go with a best combination that gives the best results. Now the other technology, karyotype, microarray, the next is the next generation sequencing. We talk a lot about sequencing based technologies. Where we use these for PGT, that is pre-implantation genetic test, for NIPT, for small gene panels or carrier screening or clinical exome or whole exome sequencings. When we can utilize this? See, this is the case where couple karyotype was normal, CMA from POC was normal, no other family history, PGS was done, 2 IVF with normal embryo failed to implant. Then we explain the consultant and we counsel the patient for ERA, that is endometrium receptivity analysis, and we found that the patient was not, after HRT cycles, she was in a pre-receptive phase. So that was the reason she was not able to conceive. After this, they have rescheduled the transfer, and after this report, they got a successful embryo transfer. So this is regarding ERA test. Majority of the time, clinicians ask that once we have done the ERA report, how long it is going to help us, or the validity of ERA test is for how many months. Research suggests that it could be for up to 23 months if you follow the same protocol every time. But personally, I will suggest that it is useful up to 6 to 8 months. So the other question is sometimes, they ask, we send for couple karyotype and couple karyotype is normal. Now what next if there is no clinical, no family history is there? So option is you can go with the carrier screening or the clinical exome sequencing. This is the case where, consanguineous marriage was there, and in every pregnancy they was having a hydrops fetalis. So first thing that came in mind, it could be because of monosomy X, or they might be a carrier of any gene mutation. The karyotype was absolutely normal, and then we counsel patient for carrier screening, and what we found, both the couples were carrier for a mutation in NEB gene that usually causes non-immune hydrophetalis. This is the second case. The patient came from UAE, non-consanguineous marriage, 3 child, all the male were affected with mental retardation, karyotype normal, microarray normal from the index case. Now they came for IVF. We suggested them for carrier screening, and we found that the female was having a mutation in SLC gene which is present on X. So she was a carrier of X-linked disease, and that is why all the males were affected. NIPT, few points I'd like to say that fetal fraction is the most important part for NIPT, that is a fetal DNA present in the circulating blood of mother. But there are factors which also affect the fetal fractions, and that affects the reporting part. So I would like to mention what are the causes that can reduce the fetal fractions. That sometimes if the fetus is having, if it is mosaic, then it reduces the fetal fraction. If the fetus having a triploidy, then it reduces the fetal fraction. Multiple pregnancy reduce. What are the maternal, factors that affect that? First is the BMI, maternal weight. The weight increases, fetal fraction decreases. If mother is having autoimmune disease or something like that, it also reduces the fetal fraction. If she is on low molecular weight heparin, that also affects the fetal fraction. So, after NIPT, always keep in mind that NIPT is a high sensitivity specificity screening test. It is not a diagnostic test. It has a high sensitivity from dual marker and quadruple marker, but even though if you find a positive result in NIPT, always confirm it by amniocentesis or CVS. But what to choose, which test to select to confirm? This is the case, first trimester screen positive for trisomy 21, NIPT high risk for sex chromosome. Z score was very high, 5.7, amniocentesis was done, fish was normal. Sex chromosome high risk, fish was normal. Meanwhile, the culture was going on in the lab. We rerun the NIPT, and it shows the same results, that the sex chromosomal abnormality is there. When we found the karyotype, she was having an iso-X chromosome. So this is the partial trisomy of XQ. You can see that there are 2 XQ arm, and so it is a partial. This is the variant of Turner syndrome. And why we missed in fish? Because in fish we use this centromeric probe. So there are only 2 centromeres. So fish was absolutely normal, but there are 3 Q arms. So, it is very important which test you have to select, and do not rely only on single testing. This is the case where, same thing, it was for trisomy 21, it was very high risk, 6.7 was the Z score. When they performed the microarray was absolutely normal. And when fish was performed, it suggests that it was a mosaic Down syndrome. So that is the limitation of microarray, it cannot detect the mosaicism. So, it is a choice of test we have to make that can detect or that can give the fruitful result to our patients. So now the second group of patients, they came to us with, some kind of family history. Like, मेरी मौसी की लड़के को ये है, मेरे family member में someone is mentally retarded, now we want to plan what we can do. So I always prefer, if the index case is there, the analysis or the testing of index case is very crucial, very important. Workup in index case, as I said, very helpful. 6-year male, global developmental delay, autism. Karyotype was done in Canada. Patient was from Canada. They came here for IVF. Couple karyotype was normal. Microarray of couple was normal. They came here, oocyte pickup was done, embryo freezing was done, and consultant called me that now what we can do, we want to go with PGS for this patient as they have a history of developmental delay and autism in the first child. Then I asked, is there any workup was done in the index case? Consultant denied. Then I said that it is not possible to rule out autism without only by doing PGS. So pre-workup of index case is very essential. But as they always came in a rush that patient has a flight, they want to fly back to Canada, we have to transfer, do help us. So looking forward to clinical history, we directly suggest them the CMA. CMA from the child, we found a loss in chromosome 8 and gain in chromosome 10. As time was very less, I wanted to recheck the karyotype of father, mother, and the index case because the loss and gain is more than 5 MB and it should be reflected in the karyotype. As the limit of detection for karyotype is 5 MB or major than 5 MB. But due to the time limit, what we did, this is the microarray report from the child. So as we were not able to, recheck the karyotype from father, mother, and the son, what we did, we take the DNA from the child and we run that DNA as a PGS sample, PGT-SR sample, just to check the limit of detection of R-KIT. What we found, there was deletion in chromosome 8, you can red dot that shows the deletion. In chromosome 12, you can see there is a part of chromosome is lifted. That suggests it is a duplication. But still, I was not convinced. So I changed the analysis workflow and I arranged the small tiles for analysis. And in these analysis, you can see there is a blue dot. So that indicates it's a clear deletion and duplication. So whatever we find in our CMA report is reflected in our PGT-SR. So my PGT-SR kit is now capable to detect this kind of abnormality. Is there any in the embryos from the same couple? We perform PGT-SR from that couple. The first embryo was showing the gain of chromosome 12. So that indicates there is something in the couple. They might be the carrier of any balance translocation between chromosome 8 and 12. But as they were running very short of time, these two embryos were absolutely normal, no gain, no loss. We reported them as normal with many annotations that transfer that and they conceive the pregnancy, but and their first scan of USG is normal. This is also the case of index child. Workup is very essential. This child came to us, was difficulty having in lifting objects, sitting, standing up, walking. She was not able to sip through straw.
Sir, last 2 minutes.
Yes, ma'am. So her CPK was very high. Muscle biopsy was done, suggestive of muscular dystrophy, atrophy. So what it could be, Ulrich syndrome, congenital myopathy, or infantile FSHD. Her DMD, BMD, SMA was absolutely normal. Karyotype was absolutely normal. So this is the case we referred. At that time, the microarray was not with us. We sent it to Delhi, and we found there was a deletion in TNX-B gene, which caused a connective tissue disease. For next pregnancy, the CMA was done, which was absolutely normal, and they delivered a very normal, healthy child. How important this DNA storage is. If we don't have the index child and if we have the DNA stem, we can, on the basis of clinical history or family history, we can offer the test to the couples or the family members. If they found any mutation related to that, we can give an option of either PGT-SR or PGT-M. what if index case is not available? So this is the case, this is the last slide, last case. No index case, no DNA was available. Clinical history of index was like, on that base we suggest KT, CM or NGS. This is the case, severe ventricular megaly. Husband's sister has polydactyly, husband's uncle also has the similar polydactyly. CMA 315 can normal from POC, lab utilize all the DNA, so we don't have any index case, no DNA, nothing was there. On the basis of clinical history, we counsel the patient and we offer them the whole exome sequencing. From the whole exome sequencing from the husband and wife, we found that they were having a mutation in CSPP1 gene and husband was having a mutation in GFM2 gene. So while we were analyzing the whole exome, the patient conceived naturally. So we asked them to wait for the 14-week scan. Ventricular megaly was there, polydactyly was there. When fetus DNA was analyzed, the fetus was a compound heterozygous mutation for CSPP1 from the mother and GFM2 from the father. So next pregnancy options for them is either PGT or donor. So take home message from me is that, karyotype, NGS or up to some extent CMA can be offered in any unknown conditions. Multiple screening should be avoided, and FISH and PCR techniques that required a prior condition or family history or clinical history is very essential and best to use in combination. Thanks from my DNA.
Thank you, Dr. Gaurav. And I request Dr. Akshay to please give
Dr.
the
Gaurav.
memento to Dr. Gaurav.
Finally, we meet.
And now we have the prize distribution ceremony for our students who had come from all the way from Vadodara, that is Sumandeep Hospital. And they have a train to catch, so I'll make it quick. Don't worry, you will get the train. Chinta mat karo.
Yeah.
Okay.
So, and the first prize for poster.
No, first prize last week.
Okay, last mein, chalo.
So first we'll give the mementos to our runner-ups. That
Runner-ups?
is Dr. Jainam Shah and Dr. Deep Patel, who spoke on study and management of rare case of mammary tuberculosis and study and management of ruptured splenic artery
Dr. Pooja
aneurysm.
Nadkarni, Prabhakar Singh, please come.
Dr. Pooja, Dr. Prabhakar,
Please.
can you please come?
Prabhu, aaja. Aditya. Yuvraj bhai.
I'll announce.
Soumya ben. Yes, sir. Host team, aaja. Hello.
This is Dr. Deep. Okay. Now Dr. Jainam for study and management of rare case of he was mammary tuberculosis, no? Dr. Jainam. You were mammary tuberculosis. Come, please. They are both runners up. Second place is being shared by two people. One is Dr. Sanchit and Dr. Kalpan. They can be ready. Dr. Sanchit and Dr. Kalpan are both sharing the second place. Dr. Sanchit presented study and management of traumatic diaphragmatic hernia, and Dr. Kalpan was study and management of case of stone formation in post-cholecystectomy stump. Arey wow. You are? Is Dr. Kalpan here? All right. Can we finish the first prize? The first prize is Dr. Savan Shah for ruptured uterus. Gynec ही जीता ultimately. Congratulations, guys.
खाली बॉक्स
Sunil.